And then what's the time now? And then hello, hello, hello.
Hi, sir. Good evening.
Hi, good evening. Okay, so we are starting at 6, no? So we are 6 minutes to 6. So it's 5:54 now. Am I right, Nandan?
Yes, sir. Yes, sir. So Nikhil sir is the
Okay,
first speaker. I see him online. Yeah.
fine, fine. Anybody wish to share their presentations? We can ask them to do. Nikhil, you want to share your presentations? Whoever is available can share their presentation. They can check their slides. Vikas sir, Devesh sir, Anindya,
Okay, I'll just
Dr.
share.
Navnath, can.
Yeah.
Hi, Dheeraj, am I audible?
Yes, sir, you are, sir. Thank you, sir.
Okay. Yeah.
Okay. Is it visible?
Yes.
Yes, sir. Can see.
Okay.
Yes,
माझा
great.
दिसतंय का?
Uh,
धीरज?
One
sir,
second.
we'll finish his and we'll allow you
Yeah.
to share.
Okay.
I'll just need to.
Fine. Yeah,
Yeah, I'll stop the share.
can.
You can do now, sir.
दिसतंय का?
Yes, sir.
Yes,
Perfect,
sir.
sir.
Can see.
Okay. ठीक है.
Thank you, sir. You can try moving the slides, sir.
Neeraj? Hello.
Hi, Ishai.
Hi.
Your,
Give me
your
5
network,
minutes.
I
I'll
think your
just
network is
introduce
poor.
and I'll look.
Ayush, your network might be poor.
Okay.
You might be sitting in office. So what I suggest you switch off your video and you can just yes. So you can try this way. Yes. Now you want to speak? Just check your audio. Everything is fine. Ayush?
Is it, can you see me, Neeraj?
Yes, we can see you, but I think your voice is breaking.
Hello?
Right now it's okay. Right now it's okay. You're on mobile or a laptop? Yeah, I think you're on mobile.
Mobile.
Okay.
I will give me 5 minutes. I'll introduce and then you go ahead. Okay.
Yes, I understand, Ayush, but if there is a hang, you can switch off the video and try with the audio only.
Is it okay right now?
Yes, it's fine. It's fine. Fine.
Okay, no problem.
Hello, hi.
I should just.
Yeah, can you hear me? Yeah.
Yes. You can check your slides.
Madam, sorry to disturb.
You can see, right?
Yes, yes. All fine. I think we are 6 o'clock already past. We can go live. Nandan?
Yes, sir.
Yes, we can go live now. Let's start and just confirm to me when we are live. So Ayush, you will directly start
Yeah, so are we live
with
now?
yes. No, so let Nandan confirm.
Yes, sir. We are live now. Yes, sir.
We are live? Sure, no? Yes. Okay,
Sir,
fine.
yes, sir.
Yes, Ayush, you can
Okay.
start.
Okay, so thank you all for joining. This is where the Society of Minimally Invasive Asia Pacific fifth annual conference sort of kick starts with the online meeting which we are having, which is basically for tubular workshop. This is just the start. I welcome all the faculty, all the delegates. You will have 3-stage training program which has been meticulously designed by the organizing committee, which includes Dr. Dheeraj, Nandan, and the whole faculty is there to really take you through different aspects of tubular surgery. I won't take much of your time. I just wanted to welcome you guys to the whole meeting and to this cadaveric section of the program. I am pretty sure you will have a great time with the great faculty and the great host, which is the Mumbai city itself. I'll see you all personally and do reach out if you have any concern, anything. I will hand it over to Dheeraj, who's taking the proceeding along with Nandan and Rohan Gala, who are the coordinators of the cadaveric workshop for tubular. Thank you, Dheeraj. Please take over.
Thank you. Thank you, Dr. Ayush. So this is a 3 days MIS tubular focused workshop, and it is planned perfectly, taking into consideration three major prestigious societies are being part of this major event in Mumbai. So the first day, this is first session is virtual, where basic concepts and principal teaching will be happening, which is going to take place right now. Second is dry bone, which will give us some technical tips. We have to do it on Sorbonne for better understanding and better knowledge with our national and international faculties. And third will be the stage just before the surgery, which will be on cadaver, which will be at the end of after post conference on Sunday at DY Patil, which will be taken care by Rohan. I thank you for providing me a wonderful team of Dr. Nandan Marathe and Rohan Gala. And over to Nandan, please take over from me. Thank you very much.
Thank you, Dheeraj sir. So, without further ado, we will start off with the first talk. Dr. Nikhil Arbatti sir will be joining us, and he will be talking about must-have and nice-to-have equipment for a beginner surgeon. So, over to you, Nikhil sir. You can share your screen now.
Yeah. Thank you, Nandan, Dheeraj, and Ayush. And so we kick on with the SMISS AP 2025. And today's talk is going to be, the first one is by me. So basically it is about the, yeah, is it visible?
Yes, sir. Can see your
Yeah.
screen.
Okay, great. So a very warm good evening to everyone, all the delegates who are there online. So the first talk by me is going to be about the tubular system. So when we discuss about the various MIS systems that we have, the tubular system is the basic one through which we start. And most of the beginners who have started their MIS journey would be very well versed with what a tubular system is. So this is for those people who are just thinking about starting with an MIS system and what is the tubular system, how well versed you can be with it. So what are the basic requirements that you require? Yeah. So we all know a tubular system, the principle is that it actually avoids stripping off any paraspinal muscles. It's a very targeted approach. You use the different kinds of tubes, but the area where you want to do, whether it's a lumbar spine, thoracic spine, or a cervical spine, it's a very targeted, it's directly at the interlaminar space or at the extraforaminal space, wherever you want to do your entire work, there it is where it's targeted up. That's the principle upon which a tubular system works. So to be well versed with what a tubular system has, we all know it consists of basically three parts. First is a bed clamp, the clamp through which the entire assembly connects to the OT table. Now this bed clamp which is available, it usually can be put in after you have done the entire draping. Or sometimes if you feel that the bed clamp needs to be well adjusted, you can fix it beforehand by any person and then put the drapes over it, and then you can pass the long arm through it. The long arm is the one which connects the bed clamp to the tubular system, that is the final retractor. In between this, you have got dilators, which are of various sizes, starting and from the basic one and goes on to what diameter depth you want. So as you start doing these cases regularly, you will be well oriented to doing all your cases with maybe one or two tube system. So these are available in various sizes, diameters, and depths. So just to have an orientation what a tubular discectomy has. So if you're doing for a lumbar discectomy or a decompression, first involves a docking, which you will be learning from the other speakers. So once you have done the marking, then this is how the entire things are put in. You can see in the C-arm, this is how you will have the tubular system placed, and you can have the image looking same wise. And this is how an AP and lateral image comes. So this is how a basic rigid tubular system works. Now, what are the equipment that you require for doing a well tubular surgery? I would say there are the four main parts. You would have the retractor system, that is the foremost, a good magnification and illumination to aid you in doing your surgery, because you're doing it through a very close space. I need to have a good magnification with illumination. Instruments to have to do in surgery, because these are not like what you're doing in an open routine surgery. You need some good equipments to help you in doing the surgery properly and with minimum of fuss and not having much of fiddling around them. And basic OT requirements. So when you go with the retractor tubular systems, there are basically two types. The ones are the expandable systems, and we have the rigid or the non-expandable ones. So what are the basic differences between the basic is that the expandable ones go from a small diameter, they expand up to the one that you can have. So you can do a single level or a two level decompression through one tube system only. While the non-rigid ones are one which are very fixed diameters. You may have from 8 mm diameter goes up to 11 and then 14. So these are in sequential dilatation depths which are available. So whichever diameter that you choose for the case, it's of that particular diameter only available. So this is the basic difference between the tubular systems. There are various retractor systems available. We have the Indian ones also and the imported ones also. In expandable, we have from Indian, the Pitker and Jesco. Also from, we know well was the Cotton system, Thomson and Globus, which is available. The rigid system we have from Pitker, Jesco, plus the imported ones. Now, what are the pros and cons if you're using a fixed tubular system? I would say the pros of using a tubular system are these are closed tubes. So once you have docked it properly and they're very well fixed to the side arm, the bed rail, they do not move at all. So that prevents any paraspinal muscles or any other muscles which are creeping into your operative field once you're doing your entire case. And so this is helps in doing a very targeted thing. So you may not need to do much of bony work also in some cases. If you are doing an alpha S1 level or an area, an interlaminar space which is very wide, you may need to do very minimal bony work, just a docking of the tube with a proper diameter at that particular interlaminar space or an extracoronal space, and you can do the entire work. So this gives a good amount of decompression, which you can do at the ipsilateral side. The tubular system can also be tilted, and that can help you in doing your contralateral decompression also. So with one incision on one side, you can do an ipsilateral and a contralateral decompression. So what would be the drawbacks if you're using a tubular system which is only fixed and which is not expandable? So those who are starting initially, you need to get an orientation. While we were doing an open surgery, we knew we need to take a 2 inches or 3 inches incision. But we are doing something from say 18 mm diameter or something like a 16 mm diameter to get an orientation in that closed space. Where is the lamina and the facet? This may take some time. And then you would be fiddling around getting an orientation. Where is the facet? Where are the spinolaminar junction? Where is the inferior lamina? Where is the superior lamina? So for initial cases, if it's a very stenotic place and you're doing with a tubular system which is fixed, you may get some time to get oriented with it. The ideal tube diameters which we use when you're doing decompressions in 18 or 19 mm. Now, if you can imagine, this is the diameter of the tube, but the incision would be something like just 10 mm or 11 mm. So it's a very narrow space to do the decompression. For beginners, this may something take time. So you may be dissuaded in doing the procedure, especially as I discussed further, you may, if you don't have a proper magnification or illumination. Now, what are the pros and cons of having an expandable system? So the larger diameter for beginners, it is like you can have a proper orientation. You can expand it up to 2 levels. So you can see the superior lamina, you can see the inferior lamina, you can see the facet, you can see the spinous process. So you can have an entire orientation of where the interlaminar space is and do the entire the bony work and the decompression through it. Also, a one tube system that is only having one particular blade system will help you in doing your decompression, discectomies, and even your fusion cases with it. So this can reduce your inventory also. Now the drawbacks are, if you see in this figure, the tubes open cranially caudally. So when they open cranial caudally, there is some amount of muscle creeping which happens from the mediolateral side. So for this, you may need to have a mediolateral blade. Now, this is the place where the inventory may increase, because you would not only require a cranial caudal tube retractor blades, but you would also require something which is mediolateral. So that unnecessarily keeps more of things in your set. But having said that, doing with this, sometimes if you are lucky and you don't get muscle creeping, you may get away without requiring a mediolateral system, only the cranial caudal work. But still, this is one of the drawbacks which I have noticed when I was doing initially, that some muscles can creep in, especially in obese people. Now, the second point that you require is magnification. So when you are doing your cases initially, I would strongly recommend start using with a microscope. I mean, loops are definitely what you could go on as you go experiencing. But for initial cases, microscopes are the must. Have a microscope where there is an assistant eyepiece also visible, so the assistant can see what you're doing. Initially, if you're doing the cases where you have a senior who is helping you out, he can also see what you're doing, and this will help him in telling you exactly what needs to be done. As you go on progress, once the senior can be replaced with the assistant or the scrub nurse. And these are very high end, which we have now available from the Pentero, the Tivato system, and the exoscope also. So these give a very good magnification and have a good depth also. So you don't need to be bending your neck too much while looking into the field. And these are completely movable about, very lightweight. Most of the good corporate hospitals have these microscopes nowadays. Once you become more experienced, you can go on to using a loops. I nowadays do in my freelancing practice most of the cases of simple decompression, discectomies, even T-lifts with a loop only. You can use a high-end loop having a 3.4x magnification. The only problem is that the depth through which you're working gets reduced. So you can compensate that by maybe standing on a stool or something so that you can get a good visualization. And when you're doing an instrumentation part, you can let go of the loop. A good quality light needs to be used. so that you can do the entire surgery properly. You can use a headlight, or the top light should be of a LED one. So these are the things that you require for illumination. Now the instruments. So once we have gone on to what tubular system you're going to use, starting with maybe a expandable one, and you have a microscope, the instruments need to be aided to help you in doing the surgery. The kerosene punches should be long tipped. If you have a bayonet ones and those which do not throw off any glare, like the carbon tipped ones or which are blackened, they would be helpful in giving you a good operating this thing, especially if the tube is something, if you're using a rigid tube and it's a small diameter. Especially, and if you go on using burrs in such cases, burrs are something that you can use to do your entire bony work. If you have the luxury of having a burr in your setup, then this reduces the operative time, because you can do the entire laminotomy, the superior, the inferior laminotomy, and some part of the medial laminotomy with the burr without much bleeding, even in osteoporotic patients. You can use a high-end burr. The RPMs can go up to 75 to 80,000, and basically I do it with most of the cutting drill bits of 5 mm or 4 mm. Rarely you use a diamond drill bit. The bayoneted ones, curettes and kerosene punches also work well. You can use with that. The OT setup, I would say you require a table where you can see the AP lateral properly, so that nothing comes in the field. You require a C-arm. That C-arm should have a flat panel so that it can be easily moved in an AP lateral with one quick swift motion. Have a technician who knows how to give an orientation of showing a proper dead AP and a dead lateral, so that you don't go into some other level and operate. So these are the same things which you need to have when you're doing your initial cases of MIS discectomy. If you have a latest table, Allen table, and a navigation, this is like a bonus for it. You can use it very well. So for beginners, I would say try using an expandable retractors. Use microscope and burrs is available. For the initial cases, when you're doing a decompression or discectomy, a 4-5-3-4 would be a good levels to start. If you have 5S1, that would be even good. But these are the levels that you should start doing your cases initially. So just to show you a small video how it looks when you're doing with a fixed tubular system, a decompression. So this is with the microscope. The entire thing, what you're seeing, the entire OT scrub nurse and the assistant can be having the same visualization. You can use a burr to do your entire bony work. The assistant will be using a suction to just take out the fumes and to take out the bony debris which comes out. And with the help of the burr, there is very less amount of bleeding which is seen. And with this high-end resolution, you can do the entire discectomy decompression very thoroughly. And as you see, it goes on to here. So this is how the visualization comes when you reach after doing the phlebectomy and seeing the nerve roots and the dura. So all in all, you would have a very good visualization. This is what the assistant, when he's seeing with the opposite field, he can have. You can see the disc which is popping out. And so your life becomes very easy if you have this equipments to help you in initial cases. And as you become well versed in using them, you can maybe progress to using a smaller diameter tube, a fixed tubes, and even with a loop. So thank you and welcome to the SMISS AP.
Thank you, Dr. Nikhil. Any questions from the delegates? They can ask in the chat box. I will request Dr. Nikhil to wait for some time to answer the queries. Dr. Nandan, you can call over the next speaker.
Thank you, Nikhil sir, for a very insightful presentation. We now have the next talk by Dr. Kshitij Chaudhary. Sir, you can share your screen now.
All right. Can you hear me?
Yes, sir, you are audible.
Okay. So, good evening, everyone. My talk focuses on understanding the applied anatomy and docking points for minimally invasive tube decompressions and discectomies. And I'll cover key differences in anatomy, exposure, and safe docking points for both these procedures. So we'll start with minimally invasive discectomy because the anatomy and the steps are close to the open approach because it is familiar and predictable. And once you have mastered the skill sets, naturally can be extended to a tube laminectomy for canal stenosis. So we know this famous neurosurgeon Casper as the inventor of the Casper retractor and the Casper pin. And he suggested a ratio of surgical exposure to the surgical target. And the goal of this exposure is one where the surgical exposure perfectly matches the surgical target. And a cylindrical port is the most efficient shape that exposes only the necessary anatomy. So then what is the requisite or necessary anatomy required for a microdiscectomy? The yellow highlighted area is all that is needed. We care about the lateral aspect of the dura, the traversing nerve root, and the disc space. And for this, you need to see the inferior part of the superior lamina, a bit of the medial facet, and the superior border of the inferior lamina. What you don't need to see is the superior lamina is in its entirety, the spinous process or any midline structure or the inferior lamina for a standard location disc herniation. And if you cannot see the requisite bony landmarks when the tube is in position, then you have to stop and reassess because you cannot proceed if you don't know where you are. So knowledge is the true organ of sight. If you don't need to see everything to know where everything is, but you need to possess the knowledge of anatomy to have that true organ of sight. The goal must be, to have a complete recall of anatomy from your memory and the ability to reconstruct that anatomy in 3 dimension in the depth of the tube in your mind. That is what is needed. These are some key measurements that will justify the use of either a 16 millimeter or a 18 millimeter port, the interpedicular distance, the lamina width, the disc height. All these measurements suggest that a 16 or a 18 millimeter tube is enough to do a discectomy. And if you're a beginner, you can start off with a 18 millimeter port. It offers a generous exposure, but with experience, you can move on to a 16 millimeter or even a 14 millimeter port if feasible. But anything more than 18 millimeter is unnecessary for a standard microdiscectomy because all that a larger tube does is it exposes the facet joint and increases your liability. On the other hand, if a 16 millimeter tube is not placed accurately, then it is impossible to see the requisite anatomy correctly. So to achieve accurate positioning of the tube, the basic principle is that the operating corridor or the tube has to be precisely in the axial plane of the disc herniation, like how you see in this diagram. And to ensure the accurate placement, you need 3 steps. One is planning of the incision, you need fluoroscopy guidance, and you need to sound the anatomy, and we'll see each of them. So it begins with planning of the incision. You take a long vertical line that marks the midline because the midline marking is useful for reorienting yourself when you are lost. So mark the midline and then mark the potential incision about 1.5 centimeter off the midline. Why 1.5 centimeters? There are 2 reasons for it. First is the distance of the midline to the pedicle in the lumbar spine is approximately 12 to 14 millimeters. So there is no point going more farther laterally. And for a discectomy, you need to minimize the angle of approach to the canal. You need to be a little bit vertical. Any incision that is a greater distance off the midline will increase the amount of conversions. And when you increase the conversion, it will limit your access to the lateral recess, where usually the disc herniation is. And that's why 1.5 centimeter approximately is usually a good distance for a microdiscectomy. So you'll use a spinal needle to mark the level. And now the tip of the needle has to be perfectly in the level of the intended disc space, which in this case is the L4, L5 disc space. But also the direction of the disc needle has to be in line with the disc. Only then you can plan the incision where the needle enters the skin. If the needle is not parallel, like this red tube here, what will happen is even though the tip points to the L4, L5 disc, your incision on the skin is way far north. And when you look down in the tube, you will not see the requisite anatomy correctly. So the needle has to be in line with the disc space. Then the incision is about 2 millimeters larger than the intended tube. So an 18 millimeter incision for a 16 millimeter tube, but the fascial incision you want to take exactly the size of the tube because it's the fascial incision that stabilizes the tube as it passes through it. In the next step, you take the smallest diameter dilator, feel for the junction of the spinous process and the lamina, and then probe it and sound it. That tactile information provided by that first dilator helps you reconstruct the 3D anatomy at depth. And you can also feel that tip falling off the inferior edge of the lamina. And that's when you know that you are at the right level, and you have to confirm that on the C-arm. That's your second X-ray. So that dilator, your first dilator also has to be parallel in line with the disc space. When you anchor the tube after dilation, when you anchor the tube, you have to press it down a bit and then tighten the arm so that there is no muscle creep that happens underneath the tube. And this is how it should look like when you look down the tube for a microdiscectomy. The target junction is the junction of the lamina with the medial facet. This is how you should see inside when you clear off the muscle. Now for obese patients, you'll have to change the convergence angle a bit, because if you keep the same convergence angle, then you, like the red tube here, you will be staring at the spinous process. So you'll have to make the tube a little bit vertical to reach the right spot if you are using if you're operating a big patient. The final fluoroscopy view, the lateral view, the tube should look like this, perfectly parallel over the disc space. And to take an AP X-ray is a bit optional. If you are a beginner or lost in the surgery, you can take an AP X-ray to confirm where you are. But generally, the lateral X-ray suffices. Now, next, let's graduate from a discectomy to LCS, and I'll just tell you what the differences are. In a standard microdiscectomy and a tube discectomy have more similarities than differences, but that's not the same for a lumbar canal stenosis, because open lumbar canal stenosis, you're doing a laminectomy and it's a midline approach, whereas for a tube decompression, you're doing a unilateral approach to achieve bilateral decompression. And that's a new skill to learn in this particular procedure. And the target of your decompression is that hypertrophied ligamentum flavum, which is about 25 millimeters or sort of from the cephalad to caudate end. And you want to reach this entire area and remove it. But your tube is only usually 16 millimeters or 18 millimeters that you are using it. So you will have to work in windows and move the tube in different areas to get to the entire hypertrophied ligamentum flavum. So you start in the purple area first and then move down and then laterally. The other difference compared to a discectomy is that the incision is a little bit more lateral, because you want a more convergent trajectory to access the entire spinal canal. Because remember, you're doing an over-the-top decompression. So you want to start off a little bit laterally so that the tube points a little bit towards the center of the spinal canal. The other difference is that your needle has to be perfectly parallel to the disc space, but a little bit superior, just bordering the lower end plate of the upper vertebra. The same goes for the initial dilator and then the tube. You can see the tube is placed a little bit north compared to how a discectomy is. So when you put in the first dilator and sound, the same thing that you do for a discectomy, but the docking points are a little bit different. The green, this dot is the docking point for lumbar canal stenosis, whereas this purple dot is a docking point for a discectomy, because this one is addressing the central canal. This one is the lateral recess. So take home points. For the principles, you don't need to see the anatomy to know where your target is. You have to learn to reconstruct the anatomy in your mind. The accuracy of placement of the tube is the key step, without which you can't proceed with the surgery. And that starts with planning the incision, having the right conversions, having fluoroscopy guidance, and the first step with the first dilator, the sounding of the wanding that is called, that helps you reconstruct that 3D anatomy in your mind. So these are the steps. Thank you very much.
Thank you, Shidit sir. Very nice message. Knowledge is the true organ of sight. If there are any questions for Dr. Kshitij, please share with them in the chat box, and we will take those questions as we go. I now invite the next speaker, Dr. Vishal Kundani, and sir will be discussing about case selection for tubular cases, how to navigate the learning curve. Over to you, Vishal sir. You can share your screen.
Is my screen seen? Thank you, Nandan. Thank you for having me around, and welcome all the
Yes,
delegates
sir. We
to
can
the
see your screen.
SMISS AP. I think this is the event of the not of the decade, but of the century, where three mega events are happening in the one venue. And I'm sure this is going to be a learning delight for everyone who seeks to learn in MI surgery. So I think these next 10 minutes, I'm going to be talking about these 6 tips to navigate the learning curve. Ultimately, we all want to have the best results that a master has when we start MIS spine surgery. And the easiest and the simplest way to this is to understand what problems can happen, because it is only by being forewarned that we become forearmed and we become successful. So one must, even before venturing into tubular microendoscopic spine surgery, understand what all problems can happen. And once you know that these problems are possible to happen, you must then also understand why do they happen, at what stage do they happen, so that you can start enjoying successful results right in the beginning of your career, like any other professional master would do. We all must understand that though microendoscopic tubular decompression seems to be a very promising, predictable, and guaranteed surgery for simpler cases, but as the complexity of cases increases, the complications also rise. And the initial first few years are the most challenging ones, which can be frustrating because smaller problems of navigating through the instruments, implants, microscopes, SIAM issues, pre-op planning issues can compromise the long-term outcome, resulting into a frustrated surgeon, resulting into poor outcome of MIS surgeries, giving a bad name not only to the surgeon but also to the branch per se, and specifically to the technique also. So one can easily avoid these problems if one is aware about these problems. Is my screen seen there, Nandan? I think. Nandan?
Sir, we can't see your screen now. Can you share again?
Okay. Somehow I think I lost the screen thing. Why? I don't know.
So we can call our next speaker by the time you can be ready with your sharing.
Sir, should I?
Now is it seen?
Yes, sir.
Yes, I think
Can
it's
see it.
yours. Yes, perfect. Thank you.
Oh, perfect. Yeah, thank you.
Can see it, sir.
So sorry again. So I think the problems can be in range of anywhere from 10 to 20%, and it can be as small as a struggle during the surgery, increased bleeding time, increased surgical time, or as simple as a dural tear, which is very, very promising, very forgiving in tubular surgeries, or it can be guide wire related issues, and sometimes as big as a facet injury or screw malposition causing bigger problems related to tubular remedies. And all these problems have a specific reason. And these reasons are very well documented in literature. We ourselves in our series have published multiple number of papers highlighting the causes of these problems and also solutions of how one can easily navigate through these without creating mistakes in the early part of career, and how to avoid these problems can actually be summarized into these 6 basic tips. So if you follow these 6 tips of MISS microendoscopic tubular surgery, I can assure you that in the first 50 cases itself, you'll be getting results like any other professional or a senior spine surgeon does. Let's take them one by one. Correct indications, pre-op planning, planning your surgery, following the tube docking principles, and decompression being precise, and during problems, be very, very calm. So let's see them one by one. The learning tip number 1 is choose the right patient. One must understand the exact nature of MIS surgery. It's a targeted surgery. It only means removing the offending agent. That means you should be very precisely clear about what the offending agent is, so that you can do a precisely targeted surgery. You can do a single level, double level, or a 3-level surgery easily by tubular surgeries. Just you must be aware about the exact nature of symptom and exact cause of that particular symptom, resulting into a targeted surgery. Simpler cases like these, where a migrated PIVD, a facet cyst, or a lumbar canal stenosis, migrated fragment, can all be taken care of very well. You just have to be precisely aware about the cause of these symptoms and perform a targeted surgery. I also recommend that in your first 50 cases, please do not choose any such case where there is a developmental canal stenosis, which can easily be caught upon your initial MRI phases also. You can actually see the length of the pedicle is very narrow in patients with developmental canal stenosis, because these are the patients where your adequate decompression may not be possible in at least early cases, and you may actually have to resect sometimes. Partial pars might be required to resect. A lot of facet amount might be resection might be required. Severe facet arthritis, which results into the tube hanging up, can result into a lot of muscle creeping in, causing further bleeding. A lot of times, a lot of muscle overhang can happen. So again, patient with severe facial arthritis, either a decompression or a fusion in early 50 cases, try not to do these cases in early 50 cases. Multi-level stenosis is not only a taxing, fatiguing surgery for the surgeon, but also for patient. The benefits of MIS surgery go down as you do more and more levels by single incision. And that is why more than 2 levels, I would recommend, please don't venture into tubular surgeries, at least in your first 50 cases. And whenever there is a very, very severe canal stenosis, please refrain from doing a tubular surgery in your first 50 cases. I did this morning a very severe canal stenosis for 2-level patient, but I wouldn't have done this in my first few years of life, because I know these are the cases which are a recipe for a dural tear, sometimes neural handling causing paresthesia, and situations like a facet rupture, facet injury can easily happen in such cases. And that's why please don't choose this. And then once you are done with simpler cases, only then you should venture into lumbar fusions versus cervical versus thoracic versus something. There's a clear-cut ladder that is laid down, that your first 25 cases should be patients with unilateral symptoms with migrated or simpler paracentral disc in L4-5-5S1 area only. Far lateral disc, strictly no in first 25 cases. Don't choose a severe LCS in first 25 cases. Once you are happy with your good results in disc cases, only then you should think about doing a lumbar canal stenosis, and then that's when you start thinking of doing a fusion where you're not adding over the top decompression to keep your surgical time minimal. And once you're done 50 of such, should you venture into your first cervical decompression or a cervical microforaminotomy. And believe me, this ladder, once you follow, avoiding these complex cases in your first 50 cases, take my point that the indication is taken well, your patient selection is well, you will not venture into any problem intraoperatively. Once you have chosen your patient well, it is extremely important to plan your surgery very well. And to plan your surgery well, like Kshitij just highlighted, you need to understand the anatomy of the patient. Every single patient has a completely different anatomy. Though we might want to think that the ligamentum flavum, spinolaminar junction, and nerve roots are all similar in all patients, but there are anomaly situations and they can really be a recipe for problem. And it's a good idea to read every single patient's spinolaminar junction, the interlaminar space individually. Looking at your X-rays and MRIs will give you a basic understanding of this. Now we must understand that a migrated fragment up or down might require your winding of the tube in that particular direction to get the targeted fragment, offending fragment from there. A facet cyst sometimes may have to be approached from the opposite side. And that is why knowing the position of your pathological offending agent is very important to have a targeted surgery without actually having to create more collateral damage, which can easily happen even with your MIS tubular surgery. Bony variations like vertical facets, spinous process angulation can easily result into a bigger problem of tubular docking, because just imagine if you have an angulated spinous process on this side and you are trying to dock your tube there, your tube will just slide laterally, resulting to facet injury or an inadequate decompression. Rotated spines, degen scoliosis, or even patients with asymmetrical facets, you may want to be very well aware about, so that you are aware where your tube is going to get docked upon, and to ensure that optimal decompression is achieved, giving a good result in long term. And these variations can easily be picked up during your pre-operative planning phase of X-rays and MRIs, and these small planning measures will help you prevent bigger problems. Sometimes a spina bifida can easily be present there, which can easily be missed if you're not done a X-ray, APV, or not read it well, resulting into a tube or guide wire migrating inside the canal, creating a bigger problem than what you're there to deal with. Once you have done this, you have planned your surgery well. Remember, MIS surgery is a purely instrument-driven surgery. So your armamentarium of instruments, right from the length of the tubes to the diameter of the tubes, to the forward rongers, to the angulated forward rongers, should be there on the table. Even before you wash up, you have to ensure that all the instruments required to perform these surgeries are present on the table before you wash up or take an incision. Believe me, my first 5 biggest struggles in the MIS world were purely because one or the other instrument required during intraoperative requirement was not present, resulting to increased struggle. And these can be taken care of. As small as a bayoneted long curette or a long suction tip not being present is a bigger problem. The fatter the patient, the more obese the patient is, the longer the instruments will be required. Bayoneted nerve hooks, bayoneted suction tips, bayoneted forward ronges, curved forward ronges to do undercutting in the lateral recess to avoid pars injury are extremely important instruments that you may want to invest upon. Having long tubular dilators is extremely important when you're really working upon these obese patients. A small mistake one people just don't pay attention to is a long cautery tip. You may have cautery tips of small size, medium size, but having long and extra long cautery tip to navigate through these dilators is very important. Otherwise, the overhang of the muscles will keep coming in, resulting in increased blood loss, increased struggle during the surgery. So these all armamentarium has to be checked upon intraoperatively even before you wash up to ensure that you're not dealing with the intraoperative problems of not having an instrument there. 90% of problems in MBD comes when your tubular docking is not proper. Kshitij beautifully highlighted about the basic principles of tube docking. And I would just like to reiterate this, that 90% of problems can be prevented if your tube docking principles are proper and if you follow the same principle that every master does. A wrong tubular docking can result into a prolonged surgical time, suboptimal decompression if you're not able to do a lateral recess decompression. If you're not able to wand it towards the targeted fragment, a disc residue may remain. Intraoperative struggle resulting into dural and neural injuries can easily happen, and a laterally placed tube can result into a facet injury, which will result into a iatrogenic instability, like you can see in this case, which happened to me in my early phase of life. And all this can easily be prevented even in your first 25 cases if you follow these principles, that always your docking has to be on the spinolaminar junction, which is the base of the spinous process. Like you can see here, particularly for all decompression discectomy cases, whereas this docking can go on the facet if you're doing a fusion case. And this has to be actually retrograde projected on the skin when you know that you are doing, like Kshitij mentioned, it is 1.5 centimeter lateral to the midline if you're doing a discectomy or decompression. However, it has to become lateral because the same incision is used for putting in the screws there when you're doing a fusion case there. Always when you're docking, please remember that these anomalies require your docking to come from the opposite side. Even though your symptoms may be on one side, but the tube docking cannot come on the same side. If the facet is vertical, if there is a narrow canal, or if the angulation of the spinous process precludes getting the docking in a proper manner happening there. In patients with facet arthritis on same side, even a partial facetectomy can result into a suboptimal result, and that's why you must dock your tube from opposite side and do a contralateral decompression from the opposite side, even when there is ipsilateral symptom there. Some basic examples Kshitij just highlighted about if you're doing a single incision surgery for 2 level or 3 level, the tube line should be in coaxial line with the disc to ensure that your discectomy and migrated fragments are removed very, very well there. The last but not the least, most problems can be avoided if you are aware about the principles of over-the-top decompression, which purely means that your contralateral decompression should happen even when the ligamentum flavum is preserved over the dural sac to ensure that there is a ligamentum flavum as a patty working naturally to prevent any dural and neural injuries. And always keep a pars under vision. Any blind bite can be a recipe to a problem. No blind biting is permitted. Using of a curved ronger to do a undercutting of the recess is recommended. However, that also has to be done directly under vision, and no blind underbiting is also recommended even with your curved forward ronges there. And remember, problems are inherent to any surgery. Same applies to minimal invasive spine surgery. The one thing that you cannot lose upon is your calm and your patience. If you have tube issues, I would recommend start from scratch zero. Just withdraw everything. Start with your docking again. Restart the docking, and you will see that you have reached a better point of start. If it bleeds, the only two enemies of MIS surgery are overhang of muscles and bleeding, because these are the two things which will prevent your vision. And once your vision is gone, a blindly done or a blind bites or a blind catch can result into a bigger problem than what you have to deal with. Dural tears are very, very forgiving in MIS surgery because there is hardly any dead space. So don't worry, unless there is a nerve root herniation, which you may want to reduce or you may want to convert it to open. And remember, decompression is not a problem if you're doing it following these principles. But if you feel that suboptimal decompression is happening due to these problems, please don't be shy to convert them into open. Ultimately, MIS or open patients are there for symptom relief, which purely comes by your principal surgery of good decompression there. So to summarize, choose the right patient if you want to navigate through the problems of early problems in your career. Prepare yourself well by doing a preoperative planning. Follow the tube docking principles. Over the top decompression is not a big problem if you follow these principles, and stay calm during the problems if they come across. Thank you, gentlemen.
Thank you, Vishal sir. That was a very nice talk and very important message for youngsters navigating the learning curve. Don't be shy to convert to open procedures. Sir, we have a question for you in the chat box. So if you can stay back to answer the questions. In the meantime, I request Dr. Rohan Gala, who will be speaking next on common errors in tubular surgeries and how to avoid them.
My screen is visible, Nandan?
Yes, we can see your screen.
Yes, okay. Just give me a minute. Okay. So, is somebody like, should I start or is everything okay?
Yes, sir, you're good to go. You can start.
Yeah, so I again thank you, the organizers of SMISS AP, for giving me this opportunity. And frankly speaking, my job has become even more easier because the previous three speakers have done a wonderful job. And I have taken the best version of each of their talks and I kind of summarize my talk. So, the common errors that we usually encounter, as my previous speakers have mentioned, about patient selection, how to position and the OT table requirements, the instrument selection and the tube docking, and finally burr usage, of which patient selection has been covered. So I will just move on to the table setup and positioning. So the common errors that we find here are bad imaging. You need a wonderful CM or a better fluoroscope to see those end plates parallel and to see that your docking on the lateral image is exactly at the intervertebral space. The patient position lordotic is a strict no-no, especially when you're a beginner, because you need a kyphotic interlaminar space which opens up so that you do minimal bony work. And placement of your microscope, image intensifier, and your table mount is a big dilemma for a lot of beginners, which actually may increase your OR time, but if done correctly, will absolutely decrease your OR time and the struggle that you will encounter in your first few cases. So this is a very poorly created image where you can see that although the docking looks good, but I don't really see the end plates, which are absolutely clear, parallel, and even the docking appears. So, even a slight angulation in both the AP or lateral view may, lead to some sort of a struggle. The second is the kyphotic positioning. The kyphotic positioning is actually important because it will open up the space, and we usually use this Wilson frame for a better outcome and minimal bony work. This is like the ideal setup where you have the microscope towards your side, you have the table mount towards the contralateral side, which means that I'm doing a right-sided disc and I have the microscope on my side, the table mount on the opposite side, the CM on the opposite side, the screen. The screen of that CM is very important because in your initial days, you want to be absolutely clear when you're docking. So you will take a couple of more shoots than you do after first 20 cases, and that is why you don't want to just twist your neck all around the theater. Instead, just have a clean screen in front of you with all the instruments available. So now what about the instrument selection? So the common error here are that the conventional instruments work, but actually they don't. And the second most important point, as my previous speaker mentioned, is about the short tip cautery. So this does not work. You need good specialized bayoneted instruments because the amount of visualization that you have through the tube is very less. So you need instruments which actually reduce your job because they will improve your visualization. Again, the long tip cautery is a must have because once you dock, you have some sort of soft tissue and you want to delineate that and want to delineate the bone to just know your orientation as well as your margins of the bone where it just continues as the phleum with that dip. Third is the type of tubes. Usually the 18 tube is used for decompression, discectomy, and the 22 to 26 tubes are used for interbody fusions. Now the conventional instruments, so using too short, too wide, or very long tubes, you just cannot have an estimate while you're using them on patients because longer tubes may impair manipulation and therefore increase the OR time. Wider tubes actually increase the risk of facet joint violation and therefore damage. They can be avoided by using that appropriate diameter and length based on location and BMI. And one has to ensure that at least more than 50% of facet is preserved. Now validate your instrument trajectory inside the tube before kind of going in. And another good tip is to measure the distance from the skin to the desired docking point preoperatively on radiology like the MR. Now this is the way that bayoneted instrument is inserted through the tube so that it improves visualization. Now coming to incision and level marking. Now this is just theoretical, but previously they used to use K wires, but that is potentially dangerous because you are going to that inferomedial aspect of the cranial lamina just at the spinolaminar junction, and there is a potential point that you may have a dural puncture. So instead, like again, Dr. Kshitij sir said that you use the first dilator and angle it medially and to feel the base of the spinous process and the inferior edge of the lamina cranially. Now dilators should be coaxial to the disc space and collinear and parallel to the segment. I mean, if you achieve this for a simple discectomy or a decompression, you have done half your job. They have to be absolutely collinear and parallel to the segment that you're addressing. Coming to docking. This is the red spot is where you usually dock. Now docking is when you have that at the base of the spinous process, you have that inferomedial place where you start docking and you walk laterally. Now common misnomer is when you start accidentally dock over the facet and then you consider your transverse process at that, you know, walking over laterally, and that is why it is very important to confirm both on AP and lateral views where you are. The image below is actually a very important example of a lordotic alignment where you've tried to dock for an L45 space, but because that tube has, it's slided down a little, you have actually accidentally landed onto the L5S1 space also. Now that is why this kyphotic positioning is actually very important, because, you know, lordotic, even a slight slip of the tube may lead to, you know, a wrong level surgery. Now, as Dr. Vakundani also said that there are certain situations where docking maneuvers change and the docking placement change, but there are certain situations like facet hypertrophy and tropism, which have to be dealt with individually and they are patient specific. Now, common errors are improper docking and docking too laterally causing the same violation and damage. Level of the tube, table mounted arm above or below the level of the table mounted arm above or below the level of the surface of the docking tube. Now this is very important is because a lot of times you must have seen that switch over of the table mounted arm is below the actual surface of the tube. Now this causes the tube to kind of lift off little and causes more muscle encroachment. So you have to ensure that if you want to go a little inferior or if you want to go more medial and it has to be fixed, you make sure that the table mounted arm is a little higher over the level of that surface of that dock tube. And every time when you dock, you apply gentle downward pressure while docking. Dock firmly on the lamina with medial angulation of 10 to 15 degrees and reconfirm on II. In case if the tube needs to be repositioned, insert the largest size dilator that you had used and then manipulate the tube the mounted arm while dragging the tube. Again, migrated disc, it is a separate ball game altogether where you don't do the conventional approach of a laminotomy and then go cranially or caudally. Instead, you just dock in the mid substance of the cranial lamina or the caudal lamina and then can perform your discectomy. So burr usage, again, the common error is drilling the mid substance of the lamina. The moment you kind of delineate the lamina, you have a tendency to just go in and burr. But the mistake you make is that you're not following the conventional burring from medial to lateral, because that will actually help you orient as well as it will delineate the flavum underneath properly. Here, if you start burring just into the middle portion of the lamina, you may, you know, just lose your orientation also. You may just not find the flavum attachment also, because the flavum cranially is and medially is deficient in the midline. So that's your starting point from where you start coming laterally and inferiorly. So you have to watch out for these things. Plus, burring at that inferomedial part of the cranial lamina also gives you the idea as to how thick the lamina is and the depth perception of the same. So always drill cranially and then proceed laterally while constantly visualizing the underlying flavum, and make sure the area while burring is irrigated enough to prevent the overheating of this system and subsequent damage. So again, my take home messages are: positioning of the patient is very important. The OT setup has to be absolutely planned before you even consider taking the patient the next morning. Orientation of anatomy with zealous use of fluoroscopy. Location is key, and different permutation and combinations are there for different scenarios. Practice makes you perfect, and there is a learning curve to this. Thanks.
Thank you, Dr. Rohan, for a very nice talk. I request you to continue in the meeting. If there are any questions for you in the chat box, you can take them. I now invite the next speaker, Vikas Gupta, sir. Sir will be speaking about tubular discectomy and how he does it, including a procedure video. Over to you, sir. You can now share your screen. Sir, we can see your screen, but you're not audible. Probably you need to unmute yourself.
Is it visible and audible?
Yes,
sir.
Am
sir.
I audible?
Thank you,
Uh,
sir.
Yes,
Okay,
sir. We
okay.
can
Thank
hear
you.
you.
Thank you. Okay.
Thank you.
Thank you for the invite for this talk. Previous speakers have talked very well about all this positioning, docking, and everything. That makes my job easy. So I'll just go ahead with the video. Okay, this is case done just 3 days back. 50-year-old female presented with episodic backache off and on, and presented with acute left-sided radicular pain. She had extensive hallucis longus weakness, and SLR was 90/50, 50 on left side. As you can see, her MRI, you can see there is a left-sided disc collapse, disc bulge with a small extruded fragment sort of, which is pushing the dura on one side. So we can assume that she has a disc extrusion which is lying on the shoulder of the root, on the lateral aspect of the dura. So we can plan our surgery accordingly. Here, one thing about docking, Rohan touched to that point, that your docking point where you are going to dock or where you are going to start your guide wire will depend on your anatomy of the disc. If the superiorly migrated, extruded, migrated fragment which is lying just behind the upper body, you need not go up to the lamina-fascicle junction. You just dock your tube on the lamina, make a window, and remove the disc. Same thing happens with the inferiorly migrated disc. You can just dock your tube near the pedicle wall, your pedicle shadow, and do your surgery. So here the disc fragment is mainly at the disc level only, extruded fragment. So I've done this at lamina-fascicle junction. So this is how I do tube multiple serial dilatation and tube insertion. In this case, I have used 18 millimeter tube, 5 centimeter long. The tube is fixed using a long tip cautery. I do remove the muscle creep, whatever is there, and then use the burr to do medial facetectomy. This is viewed through the microscope. Using a burr, I have burred the medial part of the inferior facet, part of inferior lamina, cleared of the ligamentum flavum and soft tissue, superior or upper layer of the ligamentum flavum. That's the lamina and superior facet, articular part. You can see the ligamentum flavum attachment on the lamina with the curate has separate ligamentum flavum attachment from the laminar margin. And I start with the intralamina, do small laminotomy, remove the lamina. Come laterally towards the superior facet, remove that. My end point of the bone removal is medial wall of pedicle. My foot plate, when it touches to the medial wall of pedicle, I stop. And that is the point where, because I know that next structure next to the pedicle is going to be the root. Then using a hook, I separate ligamentum flavum, make sure that there is underneath, it is not attached to the dura, or there are no adhesions there or any dural tags. So ligamentum flavum is completely free. And remove ligamentum flavum. As said, the fragment is lying here, root is here. I retract the root by putting a patty between the pedicle and the root in the lateral canal. So that retracts the root. I don't have to handle the root, and also ensures the hemostasis. So root is retracted by the patty. I have enough space there, that's the disc bulge, but I'm not going to open up disc bulge straight away. I'm going up and ensure that I'm at the upper border of the prolapse. Now with the hook, I tease out the fragment. Once the dura is retracted, I put a patty there. That also acts like a retractor, pushes the dura away from my surgical field. And with the using a hook, I tease out the extruded fragment gradually till I reach to the base of the fragment, which is coming from the disc space. So there is no, I usually don't use dura retractors. I don't like to retract or handle the dura. You can see the opening in the annulus from where the disc is coming out. My hook is working inside the disc space to pull out the tail of the fragment. You can see the hole through which the disc fragment has come out. Some fragment is still remaining. So I widened the little bit and put with a disc forceps, remove the remaining fragment. As the disc space is cleared, there is no loose fragment. I give a wash that flushes out any loose fragment remaining. You can see that tip has a small loose fragment. I ensure the hemostasis, remove the patties which are there, and with the hook, I ensure that my dural structures, nerve root and dural structure are completely free. Again, put a gel foam on the sides to ensure hemostasis. And as you remove the tube, you can see the muscle is falling back into the place. There is no dead space. That's it. Thank you.
Thank you, Vikas sir. That was very nicely demonstrated. If
One
there are any
second.
questions, they can be asked in the chat. Pawar, sir will be talking about lumbar canal stenosis and over-the-top decompression using tubes.
Can you see my screen and can you hear me, Nandan?
Yes, sir. You are audible.
Yes.
We can see
Yes.
your screen.
Yes. Okay. So first of all, I would thank Nandan, Dheeraj, Ayush, and all members of SMISS for organizing this event, and all the best wishes for this grand event. We are looking forward to it. Now we will talk about tubular decompression and lumbar stenosis, over the top decompression, and how it is effective as compared to standard open decompression. Basically, over the top decompression is a unilateral approach. You approach from one side, but decompress both the sides of the spinal canal by going over the top of the thecal sac. So, decompressing the outer bony structure, that is lamina, facet joints, before accessing the ligamentum flavum. So that potentially avoids damage to the dural tissue, the nerves, and you can access both the sides, the opposite side as well as the ipsilateral side. The opposite side, so reaching the opposite side from this on the left side from the right is called as over the top of the thecal sac. So this is a picture, typical picture in patient with lumbar stenosis. This is how the tube is docked, whether you are comfortable with whatever size tube you have, the 18 mm or 20 mm or 22 mm. In a tight stenosis, I myself prefer 22 millimeters tube because that gives you enough space to decompress the patient well. And you can access both sides, the right and the left side. And the MRI should look normal at the end of the decompression. So in a moderate stenosis or mild stenosis or with listhesis, I would prefer 20 mm tube, but in a tight stenosis, 22 millimeters tube is preferable in my hands. The docking of the tubes we have seen in the previous lectures, so I will not go into details of it. Another thing what you should have is a good OT setup. You need a good microscopes to decompress this patients, and you have a good CM to confirm your levels and to confirm your docking positions. That is very important. If you're lacking this and a burr, you should have a good burr and if possible ultrasonic bone scalpel. So if these instruments you have handy, then the things are very easy and can be done in a predictable fashion with a good recovery. As fluoro is critical, as we discussed in the previous lectures, we need to have true AP and lateral view and confirm the positions. The incision should be about 2 to 3 centimeters from the midline, and your tube should be docked at the level of spinolaminar junction, and it should be directed towards the opposite facet joint and the opposite lateral recess. This is your trajectory. So initially, as Dr. Gupta had shown, we can pass dialectors. In this picture, you can see that directing towards the facet joint. In the over-the-top decompression, you come from here and direct towards the spinal laminar junction. And your aim is to go on the opposite side without removing the ligamentum flavum. It can easily be done. The moment your tube is docked at the level of spinal laminar junction, it's directed towards the opposite facet joint. As you remove the lamina and the facet, as a lamina with the burr or with a bone scalpel, you can easily decompress that level. So this is a typical position of a tube where it's docked with the facet joint. Now, if you want to do the over-the-top decompression, you have to dock it at the level of spinal laminar junction directed towards the opposite lateral recess and the opposite facet joint. So this is a typical position. And this is another picture showing what would be the approach to reach the opposite side in the over-the-top decompression. I'll quickly show you on video where patient we had done a couple of days back. Basically, this patient had listhesis but tight stenosis. You can see here at the level of L5S1, there is a tight stenosis at the level of L5S1 with neurogenic claudication. However, this patient also had listhesis, so my plan was to decompress over the top and also fuse the patient. But as you see, the stenosis is tight, so we need a thorough decompression is necessary. So we'll go through this technique, how this is done. See, this is the lateral sagittal view. So he does have grade 1 instability. This is a typical position in the operation table. The CM microscope on the opposite side. This is docking of the tubes. And the position is confirmed at the AP and the lateral view. And you see in this picture, the tube is directed towards the spinal laminar junction. The position is confirmed in the AP and lateral views. And then since I wanted to save the bone in this patient, I used ultrasonic bone scalpel. So we remove the tissue with an pituitary or rongeurs, We remove the muscle with Bovi. You can cauterize the muscle, whatever is seen over the lamina, or you can use just pituitary forceps to remove the muscle. Now, in this patient, I wanted to save the bone because my plan was to fuse this patient. So I prefer to use the ultrasonic bone scalpel because it doesn't put any pressure on the nerves. It is atraumatic, doesn't cause any dural tears, it's safe, and gives, in my opinion, patients have a less radicular pain post-operatively or almost no pain post-operatively when with the use of bone scalpel. Another advantage is it gives a lot of bone that is necessary for fusion. So nowadays I use this scalpel widely. So you see this facet joint has been removed, and you can see the ligamentum flavum here. Now I tilt the tube more medially. Now with a put another final dilator tube, direct the tube more medially, and see now I'm removing the base of the spinal liner junction. So as soon as you remove this with the ultrasonic bone scalpel, you see the ligamentum flavum is intact, and you can reach the opposite side. The moment you remove this base of the spinal laminar junction, you can reach both the sides, and then the ligamentum flavum is removed. And there's another video, you'll see that we can reach the opposite disc space. So you can reach the opposite disc space. You can see the opposite traversing nerve root easily. You can thoroughly decompress both the sides. Then you can come on the same side and remove the facet joint and retract the nerve and do the disc space preparation. Since this patient had instability, I had to fuse this patient. Otherwise, you can just do a thorough over-the-top decompression in patients with simple stenosis without instability. And there's enough bone graft available, so you can use that for fusion purposes. So over-the-top decompression gives excellent results in patients with tight lumbar stenosis, and you can achieve thorough decompression in these patients. Thank you.
Thank you, Abhijit sir. That was a very nice demonstration. If there are any questions for Dr. Abhijit, they can be directed to him in the chat box. Moving on from decompression cases, we will now have some fixation cases, and I now invite the next speaker, Dr. Amit Jhala. He will be talking about his experience with MIS TLIF. Over to you, Jhala sir. You can now share your screen.
So can you see the screen?
Yes, sir.
Hello.
The
Yeah, okay.
screen is visible.
So I was just hearing all the talks and very nicely demonstrated by right from beginning the concept of the tube and indications and how to dock and difficulties and common errors. And after doing discectomy and decompression, what my job has become very easy because I don't have to go to all the steps which has been already shown by the previous speakers. So I am just going to show a video and how I do it, the TLIF by an MIS way or a tubular way. So basically, TLIF is done when where you require three things. And TLIF can achieve all the three goals when there is instability which is there in the spine. It can decompress the canal, it can stabilize the spine, and you can do an interbody fusion, and all through a tubular approach. So that's how this tubular approach is used. Just giving you a brief for the surgeons who are doing it for the first time, the TLIF, the principle remains the same as in open TLIF. The surgical anatomy, that working zone is at the disc space, and this disc space we are approaching through the facet joint between the two pedicles. So when we approach this working zone, you will see the traversing route. If you want to see, you can see the exiting route, but most of the time we don't see the exiting route, but we have to be aware that there is an exiting route above the working space. So you have to be very, very careful when you are doing this surgery to protect the exiting route also, which I'll demonstrate in my video also. To approach this working zone, you have to remove the inferior facet, and you have to remove the inferior facet. And to remove the inferior facet, you have to have two lines, which are one a vertical cut, which goes from the intralaminar space to the lamina, and one transverse cut, which goes from the pars and meets this. So that is known as inverted L cut, which will take out the whole facet. So, and in lateral, if you see, if you want to approach the disc space, you don't have to remove only the inferior facet, which is shown here, but you also have to remove the tip of the superior articular process. So that also needs to be removed. So it's not only IAP which is removed, but it is also the SAP or a part of the SAP or the tip of the SAP which needs to be removed. So that's where the docking. So when you dock the retractor, you actually need to see this thing very, very clearly. You should see the intralaminar space, you should see the facet line, and you should see the pars interarticularis. So this is what has to be viewed when you are doing or docking of this. If your docking is wrong, you are going to struggle, as everyone has said before. So how I do it? I do it in GA, definitely in a prone position. The procedure, first screw then cage or first cage then screw, depends on the indication. If there is a good disc space, I'll just put the cage first. But if the disc space is smaller or if there is a listhesis, then I might put the screws first and then cage. Any system is okay for me. Type of tubular retractor, I usually use 22 millimeter non-expandable fixed retractor. Docking tips, everyone is doing the docking, as I saw that in lateral, but I always like to dock in AP because my docking point has to be facet joint, facet line, which I want to see, as well as the interlaminar space, which I can see only in AP view. So docking is over the facet in AP view for me. Then you do the laminofacetectomy, remove the ligament and decompress the traversing root, and then disc preparation and cage insertion. So that will be there. So some pictorial views again. So you remove this facet, inferior articular facet. After removing the facet, you need to remove the tip of the SAP. Also, you have to remove middle part of the SAP. And then when you remove this, you will be able to see the traversing root, which is going into the let or the foramen. So this is also very important. Once that is done, you will be seeing the disc space, and then everything else is what we enter the disc space, we put the graft, and when we put the cage. This is what is a docking point. Now, when I say that I want to dock in AP, it's very, very important that there has to be a squaring of the end plate. So if you have a squaring of the end plate, it's very, very important. Otherwise, you will be in lateral, you'll be either above or below the disc space. So squaring of the disc space is very important, and you can see the facet line. So this is the facet line, squaring of the disc space, and then you can dock directly over the facet joint, dock the tube. Now, once this tubular anatomy for MIS TLIF, as I said again, you must see the interlaminar area, you must see the facet joint line, and you must see the pars, because you need to do inverted L cut, and which is very important, that the whole bone has to be used for the fusion, which is very important. So this is what the tubular anatomy which should look like when you dock the tube. Coming to the video, which I'm going to show, it's a case of a 77-year-old female having a left lowering claudication and normal SLR, normal FNST, but the patient has got a foraminal stenosis. So you can see it's a mild degenerative scoli, but it's a fractional curve where there is a foraminal stenosis. And there was no instability, but you can see the foramen in the left parasagittal view completely blocked, while right parasagittal, the foramen is quite open. So I had to do I had to remove this facet joint. So I had chosen a fusion. So this is where that's the marking of alpha in S1. This is what I would say, that this is making the end plates parallel. And you can see a very, very sclerosed facet joint here. And this is where the facet line is. So I'll dock at that particular place. So again, to orient you, you dock at, this is the facet line. This is the interlaminar area. You dock at this place. So docking has to be exactly at the facet joint line once there is a squaring of the end plates. And this is the interlaminar area. Then you have to remove this part of the bone. So this much part of the bone needs to go to decompress and enter into the disc space. So this is what is a facet line. I dock at the facet. I put the dilators in. And then that's the tube. Now it's very important. You can see in the tube that you can always see that this part of the tube or the middle part of the tube is at the interlaminar area. And this is exactly over the facet joint. So this is what I like when I'm doing an MIS TLIF. And in lateral, once, sorry. All right, just one. So this is what is the AP, but in lateral, I'll always see that the tube is parallel to the disc space, so that your working area has to be exactly in the center. So you have to check in AP as well as lateral. But I would do primary my work in AP, and lateral is just to confirm that I am parallel to the disc space. So once I dock it, so the video will start now of the surgery. So this is the dock. So this is the facet joint line. And this is the interlaminar space. So this is the cranial, this is the caudal. This is the facet joint. This is superior articular process. This is the inferior process. And then this part is medial, which is the lamina. I always use the ultrasonic bone scalpel, which is faster, which gives me a very good cut. And of course, you can use a burr. You can use even the Carrison Ranger and do a piecemeal. Or you can use an osteotome if you don't have this thing. But if this is available, it is much better. It will give you a very clean inverted L cut. And if you once you have this inverted L cut, the whole piece of bone, as the previous speaker told, you can use it for the fusion. So this is what the facet, this is what is the medial side. This is from the facet line. I'm just lifting up this inferior articular process, and you can see very nicely the whole IAP with the cartilage, and then with the help of either disc, forceps, or I have a specialized nibbler where you can remove the whole facet joint. So once you remove the facet joint, what you are going to see is the ligament or the anterior capsule as well as the ligament, and this is the cartilage of the superior articular process. So this is what is going to be visible once you remove the inferior articular process. So just widening my laminotomy there for a good access. Once that is done, as I said, then you need to remove the tip of the superior facet. So once you remove the tip of the superior facet, also you need to remove the medial part of the SAP, as I showed in the previous diagrams. So that will give you, and you have to be very careful here, because actually the traversing nerve root is here. So you don't use a larger Carrison punch, use a smaller one. And then this is again removing with the help of the bone scalpel, the tip of the SAP. And you can use that tip of the SAP again as a good piece chunk of a bone for the fusion is required. So that's the SAP which is removed. And again, as a one piece, you have to actually detach all the soft tissues from the lateral part of the tip and the lateral part. You know, at the tip, there is a tendon which is attached. So that needs to be removed. And then once that is there, you can see the ligamentum flavum. There is always a bleeder there. There is always a bleeder which is there in the lateral canal, and that needs to be actually controlled. So I'm just enlarging the, removing some more of the medial part of the SAP to get good access to the traversing root. So once that is done, you know the lateral border of the ligamentum flavum can be seen. And from lateral side also, you can remove the ligamentum flavum. You have to be very, very careful, because you are removing the ligament and you will find the dura and the traversing root there. I always like to pack the upper part, because from there is always a bleeder, which may be underneath. So if you pack it, that will give a very clear view, because bleeding is the enemy of yours once you're doing a tubular surgery. So bleeding control has to be very, very tight. So this is the traversing root. One can see, once you see the traversing root, it's quite mobile in this case, but then you slightly dissect it out and you will see the disc space. I'm checking that there is no compression over the traversing root. So that's the disc space. And this part also is very important, because once I put the gel form and patty, I'm actually protecting the exciting nerve root, which is coming from this place. And it also controls the bleeder. There are two very constant bleeders or epidural vein. One is longitudinal and one is a transverse. And you need to actually burn them. You can see always there are constant bleeders which are there. So once that is done, you will see very nicely the disc. And you have a very good annulotomy, a rectangular annulotomy that you make it. So the annulotomy is done, and then the things are quite simple because you have protected the exiting route, you have protected the traversing route. This space or the superior end plate is very well seen. So the whole disc space is in the center, and with the help of all the instruments that you have, this is the shaver. Initially, I use 8 or 9. There is a shaver, but then you have to be very careful while shaving also that you don't damage the end plates. And so that is removing the disc, and gradually, you scrape on all the disc, and that disc preparation is very important. That's a larger size of the shaver which is going there. Sometimes you are blind when these shavers are used, but you have to be very careful at that point of time also. So once that is done, you can use not only disc forceps, but you can use curettes, you can use forward disc forceps, there are end plate shavers which are end plate curettes which are available. So these are angled ones which I have. I like it very much. So I scrape the superior and inferior end plate, which is very nicely, then you can see even grating, you can get a grating sensation. Then what is required is the sizing, and that's the sizer which is going. You have to be very careful at this point of time because this is the time where you can injure the traversing nerve root. So don't try to retract much, go more laterally rather than medially. But you have to be very careful. So once the sizing is done, this is the funnel. So all the graft that has been taken, through the funnel which goes inside the disc, and you can see very nicely it is jam-packed with the graft. So once that grafting is done, the next part is, the last part is putting the cage inside. As I said that you have to be very, very careful in putting the cage, because this is the time where you will have damage to the nerve roots, or you may have a dural tears. You also do it under image intensifier, because I take sometimes a lateral shoots, because in sometimes an osteoporotic, if your cage is not parallel to the end plate, you may enter and damage the end plate also. So that's the final picture of the cage which is there. And then you have a good bleeding control. After this, you check in lateral, as I said, that the cage is very nicely placed, and then put the gel foam, and that's the end of the procedure. So that's the final picture lateral, and that's the final picture AP. Thank you very much. I'll be happy to answer any questions at all.
Thank you very much, Jhala sir. Sir, we have asked a few questions in the chat box. You can please answer that for our delegates, sir.
Okay, thank you very much.
Thank you. Dr. Nandan, you can call her the next speaker.
Thank you, Jhala sir. So moving on from a standard to more complicated case scenarios, we have Dr. Vishal Peshettiwar. Sir will be speaking about MIS TLIF in high-grade listhesis, tips and tricks for the same. So, Vishal sir, if you're online, if you can share your screen, please.
Yeah, can you see my screen now?
Yes, sir, it is visible.
Okay, so. Okay, hi, good evening. So a majority of the high-grade listhesis, when I say majority now, 9 out of 10 are going to reduce by at least 1 grade when you position them, because most of them are lytic listhesis. However, you will face this kind of scenario that is very stiff and rigid, and you'll still need to reduce that. So for that, you need to have a couple of things that have to be clear. You need very good intradiscal work. You need very strong anchors. Most of your high-grade listhesis is going to be at L5, S1. S1 being the weakest area to fix in the spine. So you have to ensure that your discal work is good, restoration of the height is good, and you have a good tricortical anchor, as you can see here. You can seek it, check it here actually through a tube. What we have done is we have put in Lenke and got the opposite cortex under vision, or like we do now is to use a navigated placement of screws. So you can see this is a grade nearly 4 listhesis, which we have put in a bicortical screw, tricortical screw to get in. These are the mainstays in our hands to get a good reduction. So a high grade listhesis is a problem in the front. So if you try to use your screws to be the reduction agents, then you're heading for trouble. You'll have a higher failure rate. Unless in a spine, the front is where the load bearing happens, and back is where the torque neutralization happens. So if you're putting screws in the front without restoring the height, your screws are going to take all the stress and you'll have a breakage earlier. However, if you have restored the anterior height, and the normal anatomy and the lordosis and the biomechanical restoration of the weight-bearing axis, then the screws only do torque neutralization, and the chances of them failing are very low. So this is what we did. We have propeller shavers. So what we did is we took out the edge and made them more blunt. So this is a locally made shaver that starts from 6 millimeters, goes to 16 millimeters, and it starts from a width of 2.5 millimeters and up to 10 millimeters. So essentially, the theory is ligamento-traxis. Most orthopedic surgeons will agree with this. When you do ligamento-traxis, you use the soft tissues of the wrist to hold the fragments together. So in a listhesis, if this is the superior end plate and that's the inferior end plate, then the annulus, the ALL and the PLL are crumpled and not doing their job. So what you do is distract them. As you gradually distract them, the annulus stretches over, and as it stretches over, it pulls the superior slip vertebra back into its place. And when you restore the height, then you put in the adequate size cage. So this cage now becomes a weight-bearing entity, and that ensures that the screws you're going to put in are more secure as compared to just letting the screws do the reduction. So this is a fairly stiff bone-on-bone kind of listhesis that is there. Positioning, I use the Jackson table. A lot of people talk about kyphosing their positions. I don't agree with that. By kyphosing the position, you're making the job easier for you, but you're making it more difficult for the patient. And our ultimate aim is to get the patient to be normal. So if you're going to kyphose a lumbar spine and then fuse it, you're going against the basic principles of restoration of the sagittal balance. So what you should do is to put them in extension, not just for this, even for a MIS or micro discectomy. When you put in extension, your canal is cramped, but your neural structures are, in my opinion, not stretched. So when you put in kyphosis, your root is and the tube is quite stretched over the disc. So pushing it is actually creating more violence on them. So I prefer to put an extension position. You should use either bolsters or 4 different pads. Dr. Badani has a Badani positioning 4 bolsters, which is available, which can be used on normal table. We use a Jackson table, and that's the positioning that is done. Once the patient is positioned, she's fairly obese here. You can see this is the position on table. I've given head high so that the L45 disc is vertical and I don't have to work in. You can see the end plate. I've marked the skin here, and that's the disc space I marked. So that's the entry point. We use a Thompson tube. You can lots of available this thing. You can see it's parallel. What Dr. Jala said, it has to be parallel to the end plate. I prefer to use a chisel because it gives you clean cuts and gives a lot of bone graft material. Even a bone scalpel or a burr is okay, but a chisel in my hands is safe. And I have this fear of scalpel causing a lot of burn locally, but that is a safer instrument to use. So a chisel, orthopedic surgeons, I think, are more comfortable using that. So you can see this here, that's the facetectomy of the inferior facet, a very clean cut of the bone. This is a very osteoporotic lady. So for the superior articular process of the inferior vertebra, I chose to use a Leschel nibbler because trying to chisel might crack into the pedicle. That's a small flavum laterally that is present that has been excised. That's the discectomy. You can see I'm using a 2 millimeter pituitary rounder to try to get into the disc. It's always good to know. I can barely put in my dura into that. This space is that tight. So what I try to do is to put in this 2.5 mm thick and 6 mm tall spacer. Not possible. So I'm using a Kerrison rounder. Then I'll use a 3/0 curette to make the space. You have to be very patient. There's nothing like fast surgery. There's only stupid surgeons who do fast surgery. Once you've got this in, gently turn it so that you're now from 2.5 going to 6. This has to be a very gentle one or the end plates will fracture and your surgery will fail. Once that is done, you have to gradually, like you're raising a punctured card for this thing, you'll have to do a gradual this thing. Make space. This is a very small curette, ring curette that we are using to make space. You can see what I'm doing now. I'm putting them thin slice in and then turning it. So this is gradually from 6 to 7 to 8 to 9 to 10, as much as it is required to restore height. In this case, I could restore it. So over the top wasn't done before. In patients where it is very, very tight, you do over the top. You go chop off the opposite facet, make it loose, and then come back here and do the same procedure. So that's gradual distraction. I think this is number 8. Gradually hold it in position, give it 10 to 15 minutes to stretch. The ligaments need to stretch. You don't need to rip them off. Elderly may have calcified vessels in the front. So you need to be very, very gentle with this. Don't try to push your way in. That's not going to work. And yeah, very gently. There will be a point when you feel there is a resistance to when the resistance starts is the time to go check under a C-arm what you're doing, that you're not over distracting or you're not biting into the end plate. Once the space is adequately opened up, I think that this will be the last distractor. This is a size 10 distractor, and this is 6 mm thick. So once this goes in, this have markings on them. So what is gone in is about 30 millimeters inside. You leave this inside for 5 minutes, then go to the opposite side, prepare the end plates there. Because if you don't do that, you won't have enough fusion surface. Use a funnel, put in your bone graft. Once the bone graft is in, do a trial, check the trial in C-arm, and then use a cage to put it in. This is a 12 millimeter cage that we put in. Expect some bleeding, like Dr. Jhala said, and then of course go in over the top. That's the over the top decompression to check, because in a high grade listhesis, if you don't check the opposite side, sometimes the facetal hypertrophy on the opposite side, the nerve root might just after reduction go and hit there, and you'll have a neurodeficit. So it's better to chop off the facet medial part to get a clear view. So that's what we could reduce to with this in this patient. And you can do it in multiple levels. Like this is fairly bad with a Degen's scoli. This is also done MIS. These are Indian implant. So you don't need very fancy, expensive screws to do it. But of course, you need experience. I would recommend that you do plenty of simple fusions before you venture into high-grade listhesis. Thank you very much.
Thank you, Vishal sir. That was a very nice demonstration. I would request you to continue to stay online. If there are any questions for you, we will direct them in the chat box. I now invite Dr. Amit Sharma. Sir will be talking about one more difficult scenario, and that is dealing with obese patients. Over to you, Amit sir. You can now share your screen.
Thank you, Nandan. Am I audible and my screen visible?
Yes, sir. We can see your screen.
Okay. So recently I did this case. The patient was actually, 80-year-old male, diabetic, hypertensive, and 2 years ago he had a trans knee amputation because of cellulitis. He is not very comfortable with the prosthetic, so he walks with the help of the crutches or walker only. His weight, even after that half of the leg gone, is still 125 kg and his BMI around 40. I saw him when he was admitted in the ICU that time, and because of multiple medical issues, even that time he was quite symptomatic and canal was stenotic. But because of multiple medical issues going on and his recent surgery because of cellulitis, we deferred the surgery. But he kept on, postponing it till the time he just recently came to me about a month ago. So right now he had right leg pain, which was more than the left leg. Right leg is the one which is amputated. He tried all the conservative treatment, medicine, physiotherapy, etc., but nothing was working. Sugar was uncontrolled, so we didn't try the epidural injection. So he is already amputated with additional disability coming from the spine. So I offered him that probably we should do a lumbar decompression instrumentation surgery because there was some listhesis also. But the patient was hellbound on getting just a decompression done because of his fear of the screws. And I also thought that probably it's a good idea because uncontrolled diabetic, so probably it's better to avoid putting any implant in. So our issues were BMI of 40, and if I put the patient in normal prone position without the availability of a Jackson table at the hospital where I work, I mean there'll be high bleeding and there'll be a lot of a high peak pressure which might have his ventilation also difficult. He might have pressure points abrasion, and depth of the tissue was another issue. How will I reach that deep tissue? On top of that, he was uncontrolled diabetic and had frozen shoulders also. So putting him in prone position was another issue. So looking at his MRI, his S1 was lumbarized. So what we are seeing morphologically as L23, L34, and L45 are actually L34, L45, and L5S1. And all the three levels, in my view, require decompression, of which the anatomically L45 was the most affected, as you can see in this close-up picture. So finally, the patient one day came and said, "The doctor, I want to get the surgery done now." So he was taken up for the surgery after the fitness and all, and you can see that his big belly. So what I decided that I will do this surgery. So one thing which I kind of tried to mitigate was his big belly. So I did this surgery in the lateral position. So I've not done many of these, maybe 2 or 3 in the past, but I thought that probably he's a good candidate to do the surgery in prone position. So I'll be avoiding all the pressure on the abdomen, which might lead to excessive bleeding at my surgery site, and will kind of not to put too much of pressure on the respiratory system also. So all the lateral position supports these at the symphysis pubis, at the chest, and the full strapping was done. So to keep the patient in the position so that when we tilt the table toward the opposite side, because in lateral position when I do the surgery, I would have to tilt the table a bit so that I can get a little bit of that vertical posture. Otherwise, I am sitting and I'm working horizontally. So to avoid that, I wanted to tilt the patient to good amount to the contralateral side. So we strap the patient very in a secure fashion. And that's the level app on the iPhone was showing that when we started, I kind of this is before the draping, we had tilted the table to about 10 degree, but in drop we had to tilt the table more so I can get that ergonomically better position. So after the position and all, we can see that his peak pressure was 18, which is like normal thin patient's peak pressure, which even that also sometimes we are not able to get. Most of the time we are working with a peak pressure of 22, 23 in the prone position. But even after his BMI being 40, we were able to have this peak pressure of 18 only. So I think that was a very good decision we took to do the surgery in lateral position. Draping. And you can see that the angle of the Siam, because we had to make it perpendicular to the spine so that we can get the true lateral, or as much as true lateral as possible. And so Siam is working in this direction. So that is another adjustment we had to do. Now in this other issue that, if you want to take an AP, you have to tilt the Siam, because from here you cannot tilt it so much that it will give you an AP. So you have to take the Siam out, flip it upside down, and then go from the top and do the AP X-ray. So we thought we'll just skip the AP X-ray, and I kind of just with the manual feel, I just try to stay as close to the midline as possible after my incisions to kind of be correct mediolaterally. So that was the lateral we were getting on the with this lateral tilt and the CM positioning. And this is the angle at which I was working, which was reasonably good enough. So because right leg pain was more, and patient is in the left lateral position with the right side being up. So I approached the canal from the right side. My plan was to do the right side decompression, but then go over the top also. So I was not unhappy with this position. And then if when I'm going from, so my dilator is right now on the right side of the spinous process. And if I have to go to the left side, which is down, I like to just go vertical, and then probably I'm working in the routine position. I didn't use the microscope also because, like using the microscope in this much tilted position, probably, probably I'll be working with a long distance. So I just use the loop. And luckily the tubes which I have are illuminated from inside. So you can see this, there's a illuminated wire you can see in the background. So it kind of gets attached to the tube. So the light kind of is thrown from inside the tube. So you don't have to worry about the headlight or your top lights from the ceiling of the OT. The depth of the patient's back, so luckily I had whole armamentarium of the tube, size 18 going all the way to the 9, and size 24 with the 5, 7, and 9 size tube available. So I started with the tube 8, and then as my previous speakers spoke about having the right instrument, the long instrument. So I had the long pituitary rongeurs as well as the long Carrison rongeurs. So they were definitely very helpful for this particular case. You can see their length as compared to this. So some of them are, about 8 to 9 inches long, which probably was required for this particular case, definitely. So there's a tube docking size 18, 9 centimeter tube. And this was the angle I was working at. So this is, I just wanted to, I will not go into the surgical details. I just wanted to bring the point that if patient has a big belly and you don't want to put the patient prone, I think a lateral position with slight tilting the tube is a very, very good option. And it gives you good vision and probably good, you can position yourself also in a nice way to do the ipsilateral. And when you have to do contralateral, obviously you are in the standard upside down position. So, it's quite doable. Now, another unfortunate incident we had was that the patient had a dural tear in trough. So, and it was in the anterolateral aspect of the, sorry for the misspelling angle laterally. So it was in the anterolateral aspect of the L5 nerve root. For this case, it was actually S1 nerve root. By count wise. So at the shoulder of the S1 nerve root, we had a dural tear because it was stuck to the underlying calcified dura. So I tried to suture it because I like to suture it. It was about 5 millimeter long tear, but I was not able to do that with the size 18 tube. So I had changed the tube to size 14, and I was able to repair. I took 3 interrupted sutures in the lateral part of the dura. With the 60 proline, and it was sort of watertight, but I was not very happy because I'm used to taking the continuous suture, which I was not able to do in this particular case because of the depth and the space constraint. So I put a Duragen patch, which is polyl lactic acid, which kind of gets stuck to the dura and is an absorbable thing. So it kind of prevents further CSF leak also. So the point is that lateral position preventing the abdominal pressure, one thing, and secondly having the deep, as Dr. Amit Jha also mentioned that he also in the chat that he also uses sometimes size 8 and size 9 tubes. So you need to have these. And just a couple of months ago, I had another patient where also I had to use the size 9 tube. So you need to have these in your armamentarium along with the long instrument, so you are not stuck. Opening this patient and doing an open surgery could have been you would have to do a lot of dissection, and also tube was the best option. And then if you're going for the tube, then you need these deeper tubes. So I decompressed the other levels also for the patient. So with the same 24 tube, I tilted up and I did the decompression at LC4. And for for L23, morphological L23, I put another incision and I kind of decompress using size 18 tube. Thank you.
Thank you, Amit sir. That was a wonderful demonstration with nice modifications made. So there is a slight change in the order of speakers, and next speaker is Dr. Basu. He will be speaking. In the meantime, if there are any questions for
Dr. Ananda, you can start. I think there is a network issue with Nandan. You can please take over.
Dr.
Aninde,
Dr.
you are on,
Anindya, yes,
you're on mute.
please unmute yourself and play in slide mode now.
Yeah, no, sorry, I was speaking with my microphone muted. Now am I audible?
Yes, yes, please.
Yes, sir, we can hear you.
Right. So I'm sharing my screen. Yes. Sorry for the entire fiasco. So right, is my screen visible now?
Yes.
Yes, sir.
Yeah. So right, yeah. So as I was I'm covering up for Varun for for his last minute pull out. So hopefully I'll do justice to the topic. My topic today is indirect decompression, the concept and case selection. So this is something which we are being using very frequently over the last decade or so, indirect decompression. And the concept is basically interbody distraction, which leads to stretching of both the ALL, PLL, as well as the ligamentum flavum, and increases the foraminal as well as the central canal diameter. That is the crux of indirect decompression. And basically, with increasing disc height, we can reduce we can reduce we can open the foramen, we can reduce spondylolisthesis, and we can basically reduce the morbidity of a posterior surgery where we have to remove a lot of bone, lot of we have to handle the neural tissue as well, with risks of injuring the dura, as our last speaker was mentioning in one of his cases. So if you can avoid going into the canal, and if you can avoid handling the neural tissue and yet achieve a good decompression, that is basically our goal in indirect decompression. And if we look at the biomechanical concepts, what we do is we distract and tension the ligaments, the ligamentum flavum and the PLL, and that leads to basically opening of the spinal canal. And in radiographic evidence, we can see that up to 55, approximately about 55% increase in canal area after lateral lumbar interbody fusion, and foraminal height also increases up to 81% in cases of reducible spondylolisthesis. So there is evidence that the ligamentotaxis and indirect decompression can lead to a significant canal and foraminal decompression and give symptom relief to the patients without having the morbidity of posterior direct decompression surgery. And these are the few of the images where you can see that the interbody, the discal interdiscal space has been distracted, and that has led to in this the image on your left, you can see that basically the buccal disc space, the buccal
Anindya,
disc.
we can't see the slides. We can't see the slides. Please
You can't?
reshare. Yes, you're on the first
Okay.
slide.
Oh, I'm resharing. Now can you see?
No, we can't.
Just hold on for a second.
Stop sharing and again try to reshare.
Yeah.
If there is an issue, we can call our next speaker and then you can again enter.
So, yeah, I. Can you now see?
Yes, we can now see. Yes. Yes, better.
Yes. So,
Thank you.
so indirect decompression, what you can see that we are able
Play
to
slides. Please
distract
play
the.
slides. Sorry. Please play slides.
Yeah. Now you can see.
It's not enlarged yet. The slide mode is not enlarged.
Are the slides moving now?
No.
There's some problem, I think. Right, there is some problem in that case.
Nandan?
Recording.
Hello?
Yeah, I think Dheeraj, while he's
Yes.
sorting his problems, we can move to the next speaker.
Yes,
and he
yes, we can. We can. Anindya, I will request you to log out and again log in. We'll try to resolve that. Okay, we can call our next speaker who is ready.
We are waiting on Hadgaonkar sir and Professor Naresh Kumar to join.
Okay.
So in the
Any other
meantime,
speaker?
I'll finish off my case, sir. I have an
Yes, fine.
osteoporosis case to show.
Fine. Thank you.
Can you see my screen?
Yes.
So I'll be talking about difficult case scenarios and osteoporosis. So as we know, osteoporosis is a huge global burden, and we are dealing with an increasingly aging population. Along with the aging population, we have more and more number of elderly people who want to be active. So they are more accepting of spine interventions. So the amount of spine procedures that are currently ongoing in an aging population is increasing. We have already discussed about the advantages of MIS procedures. However, they have a unique set of challenges when it comes to aging population and osteoporosis. So this is one of our images where MIS TLIF was done. You can see the screws have pulled out. There is a cage subsidence that has happened. So if we look at the literature review for osteoporosis, the incidence of implant failures, adjacent segment issues, adjacent segment fractures, and cage subsidence is much higher as compared to normal population. If we appreciate the image on the right side, so the first one is an immediate follow-up CT scan, and that shows that the cage is well positioned. But if we see the follow-up CT scan on the right, which is at the 2-year mark, the cage has subsided into the superior end plate of the L5 vertebra. So the outcomes of T-lift procedures and fixation procedure in osteoporotic patients are a big challenge. This is a recent article from the Spine Journal in 2025, and that shows revision surgery rates after a T-lift in osteoporotic patients are higher as compared to normal population. So how do we tackle this problem of osteoporosis? The MIS does have a role to play when it comes to porosis due to advantages of no muscle dissection. You can augment your fixation with cemented screws. There are options for indirect decompressions, which Dr. Basu will be speaking about. We have pain procedures like vertebroplasties and kyphoplasties, which Hadgaonkar sir will be covering. And along with that, there are other advantages of MIS procedures. So for your osteoporotic patients, we have to have proper preoperative planning. Most of these elderly people are frail with multiple comorbidities. So assessing their comorbidities and medical optimization is important. If we look at North American data, just 20% of patients are doing dedicated imaging for osteoporosis. So elective cases who are being posted for fusion procedures, only 20% patients are actually doing a DEXA scan. We don't have exact numbers from Indian population, but I'm pretty sure that this number is going to be even lower when it comes to Indian population. So for osteoporotic patients, adequate preoperative planning and ideally getting a DEXA is required. It is very important to plan your implants. So planning for a longer construct or augmentation with cement is necessary. If it's an elective procedure, you can start these patients preoperatively on anti-osteoporotic meds. At the same time, appropriate counseling and taking an adequate consent is important. Having this consent conversation where realistic goals and expectations are set, including need for compliance with post-op osteoporotic treatment is necessary. Intraoperatively, even positioning of the patient has to be done properly. Even a bad positioning as well as movement of the C-arm can lead to fractures in these fragile patients. You can utilize newer advancements, including navigation, robotics for better screw placement. You can plan your constructs with cemented screws or go long. Use indirect decompression strategies where large cages with a larger end plate coverage can be utilized. As we move on to better technology and newer armamentarium, we still should not miss out on the basics of spine fixation. So the basics are a good end plate preparation. Make sure you do not rupture the end plate and preserve the subchondral bone. While cementing, you can do it with appropriate fluoroscopy guidance and low pressure injection of the cement to prevent iatrogenic complications. For your screws, you can undersize the holes, avoid over tapping. In terms of post-op care, you can protect these patients with a brace. Bending and torsion related activity has to be restricted for the initial 3 months. Very important is compliance with medical therapy. So these patients have to be put on appropriate anti-osteoporotic meds. You have to have serial imaging in follow-ups. Keep a watch for PJK and adjacent segment fractures. These patients should undergo structured rehab under the guidance of a physiotherapist. So this is one of our cases, a 70-year-old lady with L4, L5 spondylolisthesis. So she had complaints of long-standing mechanical back pain and neurogenic claudication and was electively planned for a T-lift procedure. This was an MRI scan. Her DEXA score was minus 3.5. She was put on teriparatide and optimized for 3 months prior to the fixation. So this is what we have done. So sequential guide wires were passed. Following passage of guide wire, the kyphoplastic cannula is passed on top of the guide wire and standard bone cement is then injected. After injecting the cement, before it solidifies, routine MIS screws are then passed on over the guide wire. So this case, we have not used fenestrated screws. These are the standard MIS screws that are being passed. Following passage of the screws, we then move on to sequential end plate preparation, and a cage is inserted inside. So this has the final X-ray picture. Thank you.
Right. Should I try to share my screen again and see if it works?
Yes, sure. You can try that.
Yeah.
And understand that she's used to it. Yeah, I saw you were presenting. So it's okay, it's okay. Now I'm ready.
Yeah. So I'm again trying to share the screen. So is my screen visible now?
Just your name is visible. We can't see your presentation.
My presentation is cannot been seen.
Yes, we can't see your presentation.
Yeah.
You can log out and log in again sometime. That is how
Yeah,
it
that's
works.
what we did this time actually.
No, okay.
Yeah. Can I present mine? Ayush?
Ayush, you want to present? So we can see your presentation, but it's not in slide mode.
I know. Actually, I'm in Chennai and this
Okay,
hotel's
fine.
internet connection
Okay.
is not good.
Okay, no worry. Can.
So should I present Dheeraj? Shailesh here.
Shailesh, let him finish now. Let Anindya finish with the same presentation. Yes.
Okay.
You can.
Yeah. So yeah, I mean, we were discussing about indirect decompression, and in this image, you can see that basically once you distract the vertebral body, you can basically you can basically increase the foraminal height as well as you can increase the central canal diameter. If you look at the MRI here in the image on the left side, what you can see is basically the body. There is a grade 1 spondylolisthesis along with buckling of ligamentum flavum. But when there was the disc space was distracted, you can see that the central canal, the vertebral bodies were placed back in their original position, as well as the buckling of the center of the ligamentum flavum, and the buckling of the PLL has also disappeared. So if you look at the comparison between indirect and direct decompression, we can see that the procedures that can achieve indirect decompression are mainly LLIF or XLIF, OLIF, and sometimes MIS or endoscopic fusion procedures can also achieve indirect decompression. But what we preserve the posterior elements in indirect decompression, and what we do is by placing a bigger size cage, we try to achieve jacking open of the foramen as well as the foraminal height. So if you want to look at the surgical techniques, XLIF is something which is I think not many people are doing here in India, but I was trained to do XLIFs in my fellowship. But the XLIF is where you go through psoas. You find an anudal plane in the psoas where there is not there is lack of uh, uh, there is lack of the there's lack of neural tissue, and you go into the plane and you basically jack open the you interior increase the interdiscal space. But OLIF is something which we do regularly. OLIF where we go anterior to the psoas and with larger cage placement, you can achieve a good foraminal height restoration. ALIF again is more popular in L5, S1 levels where OLIF is not that popular. And MIS TLIF, sometimes you can put in a bigger size cage, and especially in cases with lytic listhesis, where you just need to stabilize and restore the foraminal height. You can use an MIS TLIF as well as a tool for indirect decompression. For case selection, ideal case would be a one with foraminal stenosis, with moderate canal stenosis. Very severe canal stenosis again can have good outcome, as as Dr. Jhala mentions in his lectures. But I'm very I'm not very comfortable doing indirect decompression in very severe canal stenosis. For me, a patient with a instability with mild to moderate canal stenosis with grade 1 or grade 2 listhesis is an ideal candidate for with a preserved disc flexibility on dynamic image is an ideal candidate for indirect decompression. And of late, the two most common indications in my practice for indirect decompression using an OLIF for lateral surgery is adjacent segment disease, where I can avoid going revising the implants from back, which is basically a surgery through scar tissue, and basically it's an open messy surgery where there is a lot of blood tissue and you have to operate through scar tissue as well. So in that case, we can go through a virgin plane, through the lateral plane, and we can achieve a good foraminal height restoration as well as stabilization and indirect decompression for adjacent segment pathology. And it is very useful, the indirect decompression principles in sagittal and coronal realignment in degenerative scoliosis. So where there is basically lateral subluxation of the vertebral body, as well as you have to restore sagittal balance in these patients. So in that case, restoring the the intervertebral height, restoring the disc space gives you the added advantage of giving more lordosis to the patient, you can actually realign the patient sagittally much better than direct decompression procedures. So an ideal case would be like this: a patient with a moderate stenosis with an instability on dynamic radiographs, and where you can see basically there is the facet joints are not fused, and there is dynamicity noted in the radiographs as well. So this is kind of an ideal case for achieving indirect decompression. So where I would not do an indirect decompression is basically where there is severe bony lateral stenosis. If there are facet cysts which cannot, there are osteophytes basically in the foramen, there are extruded disc fragments, and the patient has a rest pain. So if the patient has rest pain and actually a prolapsed disc with a disc fragment in the canal, that patient will not do well with indirect decompression procedures. And before we plan for an indirect decompression procedure, we have to see whether the facets are ankylosed or not, whether there is ligament calcification or not, because basically you need to have these vertebral bodies mobile before you can jack them open and achieve indirect decompression of the foramen as well as the central canal. And basically when you're jacking open the vertebral bodies, jacking open the foramen, you need to have good strong bones, and patient with osteoporosis have a risk of subsidence. And if you have a case subsidence in an OLIF for a lateral procedure, basically your decompression is basically your surgery is a failure, because once the foraminal height again collapses, the disc height collapses, your indirect decompression that you had achieved by distracting the disc height, that fails. So if there is a subsidence in the cage subsidence, the surgery basically fails. So you need to rule out osteoporosis before planning for a lateral procedure. Not going much into the history of OLIF, you have to identify if you are since OLIF is something which I'll be discussing. There are other methods now like the KLIF and all, but I don't have any personal experience, so I'm not venturing into that. But if you planning a patient for OLIF, you have to identify a safe corridor which is between the vasculature as well and the psoas muscle. And in the preoperative MRI, you have to see whether there is a safe vascular corridor for you to go in. Sometimes you can have vascular anomalies as well, where you can find you can find low bifurcation or accessory arteries, or something, you can find the vasculature, the anatomy is not normal, or basically if there is a history of abdominal surgery in the past in this patient, multiple abdominal surgeries, you can have a lot of scar tissue. So those are patients not ideal for doing a OLIF or a lateral procedure, because in OLIF you have to go through this retroperitoneal corridor. So after you put in an incision on a lateral position, you basically you put in your fingers, go and try to retract, try to basically go to the retroperitoneal space and work your way towards on the psoas muscle and towards the vertebral body. And once you identify that margin between the psoas and the vertebral body, there is where you put your guide wire, and that is the place for docking. So, and a very important thing in OLIF surgery is the orthogonal maneuver, because you're operating with the patient lateral, and your corridor, your corridor is basically in a angle direction to the vertebral body. Your cage placement will have to be from the lateral side. So you going with an angle which is going towards the opposite foramen. When you start going into the disc space, then you do an orthogonal maneuver where you turn your instrument and align it along the disc space, and then you do your disc preparations, you do your trialing, you do your curating. All these maneuvers will have to, all these procedures will have to be done with an orthogonal maneuver. That is something you have to keep in mind while you're doing a OLIF surgery. And again, vascular anatomy, very important. You can have all kinds of vascular anomalies, and while doing the surgery, you have to be very careful about something called an iliolumbar vein, which can be a source of torrential bleeding if you damage it while putting your Casper pins, or while putting in your while anchoring your retractor system. So you have to be careful about this iliolumbar vein, because normally it passes over the L5 vertebral body, and you have to be careful not to damage it. So a very important part of this patient selection is looking at the MRI preoperatively and identifying a safe vertebral safe corridor for doing this surgery. You can have these low bifurcations. You can have a very small corridor between the psoas and the vessels, the iliac vessels or the aorta. And in certain cases where you might feel that you're not confident of going in through that small corridor, either you can do an alternative procedure, or you can take the help of a vascular surgeon to mobilize the vessels for you to create that corridor. The lumbar plexus and the nerves are there, iliohypogastric, all these nerves will be there, and you have to be careful while if you identify a nerve, you have to be careful not to damage it. Again, as we said that all this I have mentioned already, and patient positioning is very, very important. This is how I position my patient on a lateral, and I do a bend to open up the space between the rib cage as well as the iliac crest. And that and the lateral positioning of the patient, what it does is basically it pushes the peritoneal content, the gravity pushes the peritoneal contents down. So once you're through the abdominal musculature, then you can actually go to the retroperitoneal space very, very easily. With this surgery, you have to be careful about injuring a lot of structures which we are not normally acquainted with, like the sympathetic chain, femoral cutaneous nerve, ureter, genitofemoral nerve. All these kinds of things can happen. But I think it's very important to go through your first few cases with a lot of cautiousness. With either, if you're not confident, take the help of a abdominal surgeon. If you're confident, then go ahead with the procedure with a bigger incision to start with, where you can see the structures under vision, or you can take a help of a microscope while doing the surgery, while trying to find the anti-psoas plane inside the abdomen as well. So again, prerequisites, I'm reiterating, favorable anatomy is very important. Mobile facet joints, again, very important, because if the facet joints don't move, you can't achieve indirect decompression. So if you see one of our cases where there was an instability on flexion extension radiograph with some stenosis, and we could do a OLIF in this case only through a lateral incision, and a significant foraminal height was restored, and this patient did well in follow-up. Again, another patient with quite significant stenosis. This patient also had a instability in flexion extension radiograph, treated with OLIF with without any posterior instrumentation, with only anterior instrumentation. Again, another case, a patient with claudication, again instability on flexion extension radiograph. In this case, we did a OLIF as did a lateral surgery and then put percutaneous screws from the back. So these are all the options that you can use basically to stabilize the spine, depending on the patient's affordability, depending on the the kind of setup that you're working in, or the bone strength and the feel that you get from after putting in the cage from the front. Degenerative scoliosis, again, it's a very important indication for OLIF surgery. Degenerative scoliosis, it's probably one of the two indications that I'm doing OLIF right now. And again, adjacent segment disease is this is again one of the cases where this patient had a spinal fusion elsewhere, where you can see that she developed adjacent segment disease at L3, L4. And to devise this surgery from behind, you'll have to basically do a long incision surgery with quite significant blood loss. You have to take out the the rod, the inies connected with the level above. So it's quite a tedious surgery, and you can avoid that by just going in from front. And you can see that we have achieved quite significant amount of disc height restoration after doing the OLIF procedure. And we put in the screw, we stabilized by vertebral body screws from the front. And this patient again did quite well with a less morbid surgery in follow-up. So thank you for your patient hearing.
Thank you, Anindya sir, for giving a nice talk despite the logistical challenges. We now have the next speaker, Dr. Hadgaonkar sir, and he will be discussing about various cementing options, including stentoplasty. Hadgaonkar sir, if you can share your screen now.
Yeah, thank you, Dr. Ayush Sharma and Dr. Nandan, Dr. Dheeraj, and team SMISS for this interactive session and online, because it sets the ball rolling. Is the images seen now here?
Yeah, we can see, sir.
You can see, na? Okay.
Yes,
Because it is a quite extensive topic, but I will just try to cover up with short understandings. Yeah, the background. If just a second. Can you see the share screen, Ayush?
So it was visible previously. Now we cannot see it. Can you reshare, please?
I'm just trying to that. Yeah, I'm just trying to.
Yes, sir. It's visible now.
It's visible. Now it's, I think it's okay. All set. Yeah. So now I'll just for everyone's understanding, this vertebroplasty is a technique which was described by a radiologist from France in 1986-87 for tumors, where he put in the cement, and he was very lucky, and he found that the pain relief was quite significant, and this was mainly started for the osteoporotic fracture and mainly tumors, and eventually it developed into osteoporotic fractures and various things. Now we are using it for metastatic fractures, myelomas, and various things. Principally the thermocoagulation effect. If you see the first image here, we are putting the needle, and in vertebroplasty, we always try to put it from the 11 o'clock on the left side if you're doing the left-sided, or 1 o'clock for the entry of the needle to go inside the pedicle. And you try to go inside, identify your exact location. A lot of time there can be vertebra which are very small, or we have to identify where exactly is the pain generator, and we have to aim at that level where we inject the dye to confirm, because there is basivertebral vein, which is again can lead to a lot of complications. The cement leakage is from that. That's number one. Second is various, if it is a fresh fracture, I do not recommend vertebroplasty for 3 to 4 weeks unless the scaffolds and the fracture becomes reasonably gummy, where there is less chance of the cement leakage. The cement can leak backwards toward the canal. I have myself done 2-3 revisions for patients which have been referred from elsewhere, where there was a backtrack of the cement and there was devastating complication. Monoplegia also in one patient I had operated. Also, the cement can leak into the anterior side superiorly anywhere, and that's not good. Therefore, we do not have a control unless you understand the principles, thermocoagulation effect. You don't need to put a lot of cement to stuff it, because we want, it's a cavity, bone is fractured inside, the scaffolds are creating trouble because nerve endings are also giving that pain. We have to stop that pain, and when the hot hot cement injection is given inside, so that really kills the nerve endings and you get that thermocoagulation effect inside and pain relief is achieved. Also, they say you give the mechanical stability by putting cement inside. But I have done a lot of vertebroplasties in the past, around many years. But when I came to know about kyphoplasty, again, this is 10, 12 years I started doing, and I was more happier because here in kyphoplasty, you inflate the balloon, and the balloon goes inside the vertebral body. You inflate it slowly, and you make a very nice scaffold of the injured vertebral body inside, and there is a chance of you to distract. Positioning gives you good distraction, but you can see it here how I am putting the balloon, and it is inflating, and then I deflate, take the balloon out, and I put my cement, and that's a very, very good thing. I personally, if you ask me, I personally prefer kyphoplasty. In last couple of years, I have done maximum kyphoplasties, not vertebroplasties, and that is with a very great safety for the patient. The problem was it was little costly, but a lot of companies have come down with the cost and they are not extensively costly. And again, in recent time, 3-4 years back, I started doing stentoplasty, where we've realized that we are just making a scaffold inside the vertebral body, like making a shell and making it, where you are putting the cement, the PMMA. But if you put some structural strut-like structure, this is a cobalt chrome and this was DePuy, but now there are companies which have come up with, because there's a very good shielding for this, and they don't, if you use this stent, they are absolutely strong, and they really go from a very small needle. There are very beautiful systems which we actually can use for the stent. So first you have to do the balloon inflation. 2-3 times I do the balloon inflation and come out. Then I put my stent and then I inflate. I acquire a good space. I do it in navigation so that I know where exactly I want to go. And that's the beauty of this. And then we put the cement. So it's, I think, giving very good outcomes. And we have done a couple of cases, quite a good experience with us and in this. And I will not go into the basics of this. And this was our paper of vertebroplasty, where we had shared the devastating complications. And this is long back, 14 years back paper. And we used to use the gel foam technique, where we put that gel foam inside. After the dye, we put gel foam, where the particles of gel foam will spill around the area. And then we again put the dye and confirm that the dye leakage is significantly less. And then we inject our cement for vertebroplasty. Again, we are not going into the detail, but goal of surgery is not only pain relief, but achieving some amount of vertebral sagittal balance. That's also important. And as we start doing surgeries, we realize that this is also having some importance. If you're doing it, why not do better? The kyphoplasty, I think, is a very good technique, and it's matured over the period of time. We are doing it for nearly 14, 15 years now. And this is becoming more and more common at various places. And after the kyphoplasty, I think what people in heart surgery, the angioplasty, what they do is inflation of the balloon, putting the stent, and allowing the vascularity, what we normally hear in angioplasty. Similar principle is there in stentoplasty or vertebral body stenting or jack-up procedure, spinal jack. And that can be done where you really can get this and you can put your cement and you can get the desired outcome. All these indications are nearly similar, but in stentoplasty, recurrent collapses, severe kyphosis, we can actually do multi-level stentoplasties and even for multi-level issues. In kyphoplasty, we can use, in hybrid where we do the kyphoplasty and cementing where we can actually give desired or better outcomes. And I think comparison is not right because each procedure has its own essence. Even vertebroplasty also, if done nicely, is giving wonderful results and it's very cost effective. So why not give vertebroplasty in a country where we have large number of poor patients and this procedure can be really done in very, very less cost. You have to be very careful. See, using the dye is very, very important because you have to avoid pulmonary embolism is very, very notorious after the plastic because cement and it has got very high risk. Therefore, it's always better to monitor these patients. And I personally do these cases under local anesthesia because I want to see the movement of the legs. I want to have a dialogue with the patient. And, all this is normally we talk about stabilization, restoration of height, minimal invasive and safety. Again, we'll not go into the same. Limitation is limited efficacy, risk of all these things. And in old fracture, we really can't do anything much. And probably it's not required also. We'll just start with a quick case. 81 male, back pain and persistent pain, not getting better. And here, what we've done, we have done the genial map, and where we have seen that it's coming from the opposite side, the saline, good wash was given, and then cement was inserted, and we got reasonable pain relief. Patient was symptomatically better. But this is again a problem of vertebroplasty. So we have to be very, very careful. We have taken these images and these are the complications which we can see in various cases where cement can leak. Kyphoplasty, as I mentioned, the balloon inflation, it's a bit costly, but eggshelling to prevent the cement leakage, it gives a very good contour within the eggshell. And it is really a wonderful procedure. And again, in various contraindications for the procedure where severe cardiopulmonary disease, bleeding disorders, and infection we should not do. But anterior column reconstruction and sagittal balance restoration is beautifully achieved in kyphoplasty. You see this case where there is the bone is iron spawned, back pain, significant pain and fall. He was not better with medical management. The pain was worsening and there was a reduction in disc height. Pain was 9 on 10. We did the balloon inflation and we did a kyphoplasty and single level fixation. As patients with the spondyloarthropathy can really have significant pain because there is a chalk stick or carrot stick fracture. We planned for fixation and this patient really did dramatic pain relief and he was sent home the next day because everything was done MIS. Again, pain is an important thing. Not all patients with neurodeficit needs, it's not every time neurodeficit, but pain also, which is not settling. We can consider this procedure at an appropriate time. And if you do it, my normal take is wait for at least 3 to 4 weeks or maybe 5 to 6 weeks. Medical management works, but if it's not working, then these patients are the candidate for the procedure. And stentoplasty, as mentioned, You really can inflate it, and this is the cobalt chromium stent. It really can get inflated nicely. You can do bilateral, but it's again costly, very costly in India. But I think the local manufacturers will come in and they will help us. And this is our case where we have restored the sagittal balance, we have restored the anatomy, and this patient is 1.5 years, significantly fine, doing everything as per the requirement. And that's the beauty of vertebral body stenting. We have done a couple of tumor cases with vertebral body stenting, expansile L5 hemangioma, where we have decompressed. There was a Kodak equina with this. We decompressed it, restored the anterior height. It's all under navigation. If you can see, we did the S2AI screws as well, and we did the balloon.
The most important step of a kyphoplasty and vertebral body stenting should is removal of the balloon, which you have to do it very carefully.
You have to be very careful when you are trying to remove the balloon, because you've already done inflation inside. And if it gets stuck, then you are at trouble. You have to be very, very careful when you are trying to do that. It's a small balloon.
What's wrong with you?
This is the balloon. I'm just showing few cases. And we can actually check it in navigation. And so far, we are lucky to not have any major complication with kyphoplasty or stentoplasty, even the vertebroplasty. I think if you select your patients well, you will really get out of any major problem. And you need to explain the patient in detail about what is the procedure, what complications we can have, and how we are going to deal with the complication, because patients feel that it's just a 1 day procedure. A lot of people will say go home day. I always make sure that the patients are admitted for 1 day, those who are elderly patients, and I monitor them very well. With a lot of comorbidities, I even keep them in HDU for a day to monitor. Once they're comfortable, next day I check everything medically, they are okay, and then I normally send them. I am not in a rush to send them, because I want the outcome. Sending home is not important in patients who are really not walking or doing well. It's that they should be happy, and we should try to aim for the outcomes in these kind of procedures. Thank you again, the team SMISS, for giving this wonderful opportunity.
Thank you very much, Shailesh. Please be with us for taking the questions. Yes, so over to Professor Naresh Kumar. So we have kept the best talk at the last. So thank you, Professor Naresh. It's an honor to have you, sir. And to know for everybody, this Professor Naresh was my mentor during NUH Spine Fellowship, and he's an exceptional academician and a renowned researcher. He has 100+ research papers, and that to a very high impact scientific publications. And it's indeed a pleasure and fortunate enough to have you here, sir. Welcome, Professor Naresh. And please enrich with your knowledge, sir. Thank you very much.
Yeah, hi. Can everybody hear me? Hi, can everybody hear me?
Yes, sir, can.
Okay, good. And you can see my slides.
Yes, sir. Can see your
Okay.
slide, but
Yeah, this is clear to everybody?
yes, sir, very much. Thank you.
Good. First of all, I thank the organizers, SMISS, for selecting me to give this talk. And my sincere thanks to Dhiraj, Ayush, then Nandan to organize this for me. And I can see in the group, I can see Dhiraj, I can see Vishal. Both of them have been my fellows and now very top-notch surgeons in Mumbai doing good work and training the next generation of people. So I thank all of them. I also like to thank Harsh, who helped me prepare this talk. So let's go on to the concept of MIS separation surgery. This I can say this is one of my surgeries which I'm most well known for because I've contributed to the development of this surgical technique. I, I think we can answer some of these questions towards the end with, what is considered safe radiotherapy, SBRT or EBRT. Let's go on to the talk itself. These are some of the questions which may be raised by the listeners in the end. So the concept of separation surgery evolved by the fact that you want to be minimally invasive. You want to introduce early radiotherapy, especially stereotactic body radiotherapy, in order to get good local control. The basic idea is to keep the surgical insult as minimum as possible. Now let's see what is separation surgery. So now what we do is the tumor is in the vertebral body and you want to create 2 to 3 millimeter of space. Now, if you can see the slide number B, here you can see we have created 2 to 3 millimeter space around the spinal cord. You have left the rest of the shell of tumor intact. And that will be taken care of by stereotactic body radiotherapy or systemic therapy of cancer treatment. So I have looked at this. This is one of my publications where I looked at the evolution of treatment strategy in metastatic spine disease. The major turning point was 2005 when the radiotherapy was replaced by combination of surgery with radiotherapy, and 2015 or 16 where percutaneous pedicle screw fixation treatment became an established treatment. And I was one of the first surgeons in the world to have introduced this concept, and some of my publications are way ahead of what Americans have done or anybody else. So me, Tancioni from Italy, and one of the other guys from Korea introduced this concept of using percutaneous pedicle screw. And this I talk about the honeymoon period in this operation. So that means if the tumor is less aggressive, then the honeymoon period is longer. Doing a separation surgery is far more fruitful. If the tumor is aggressive, then the honeymoon period is shorter, by which I mean that the tumor doubling time is less and the tumor can come back to replace whatever space you have created. I think I can take it in the question session if you want. Then in the last 2 decades, obviously, stereotactic body radiotherapy, minimal access surgery have been established as a method of treatment in tumor surgery. Decompression stabilization are cornerstones. They can be done by MIS or open technique. The two major indications for surgery are neural deficit and spinal instability. Obviously, the surgery does work, and that's why we are doing them. Positive outcomes are known. This is one of my algorithms where I show that symptomatic metastatic disease, if they have a neural deficit, can be operated by MIS stroke open surgery with a combination radiotherapy or this one, chemotherapy. Or if you have a non-radiological compression, that means there's only tumor involvement and it's a pathological fracture, it can also be treated by MIS stabilization. And these are some of my publication where it shows that there is a great place for doing MIS surgery in these patients. Now, coming on to the concept of tube. So I personally like the Mars retractor system, and I use this very frequently. I also use two simple retractors because these Singaporean patients are not very big, and hence sometimes Mars retractor, the smallest Mars retractor is about 50 millimeter or 5 centimeter, and the soft tissue in Singaporean patients can be less than 5 centimeters, and I can get away by doing some using retractors itself. Now let's take some examples. I can show you some videos. Now this is a 72-year-old man with a CA prostate with metastasis. You can see that he was neurologically affected. Both left and right side, he's got some right side more affected than the left. Now you can see the thoracic spine, not so clear, but there is tumor. It's riddled. The spinal column is riddled with tumor, but T7 is the one that where there is cord compression. Now this is Bilski type 2. That means the cord 2C, where the cord is fairly compressed, and this requires surgical addressing surgically. Now this you can see that, and you can see maybe it's Bilski 3 in this place, and with contrast enhancement, you would know that this is likely to be vascular. Ideally, I would have liked him to be embolized, but I did it without embolization. The blood loss, even with the MIS, was roughly 400 mils in this case. And then you can see, now you can see that the older concept would have been to replace it with cage, but with separation surgery, I'm able to let them have systemic chemotherapy at about day 7 to day 10 and follow it up with radiotherapy. Now this is now you can see that this is directly onto the meat of the surgery. The spinal cord is here, the head is on the left side of the screen. This is spinal cord where my arrow is. I have ligated the nerve and cut the nerve. One end is here, one end is there. Now this can helps us to gently roll the spinal cord, or with this suture here, we can gently give a traction and roll. I would say not to retract the spinal cord in the thoracic spine, quite dangerous, but you can definitely use a nerve root retractor. I've made a square window, and what we are doing is creating a depression or a crater. As you can see, a lot of tumor material is coming out. He is bleeding quite a lot. You can say there's brisk bleeding. And Dr. Harsh, who's he's also in the listening to us. He was giving me a hand for this case. Now you can see one of the last few steps would be to use a McDonald to press the posterior part of the vertebral body so that we can create a space. Now this is T7 vertebra. So you can see that I am curating out. So it's a combination of Keresons, combination of a curette, and the very fact, and another important thing to remember here, the stay suture, which is on the nerve root, which is connected to the cord. I don't think you should ever put a artery clip on it, because by chance somebody pulls it, the game is over, because the patient gets totally paralyzed. One shot. And this, I'm using my triple sandwich technique. That means I fill it up with fibrillar Surgicel and Flow Seal. And well, this one does not show that we've used a, and this is the check radiograph of this patient. Again, taking you through another case, CA breast, L3 metastasis to the spine. You can see that there is tumor here, and it's not L3, it's L4. You can see the tumor is here, and her symptoms were mainly related to the radicular compression, nerve root compression, and severe pain. And she did not require a major anterior reconstruction, but a separation surgery. Now you can see that there are some, we have been able to embolize this patient before the operation. And there is a stent. You can see the IVC stent is to, she had basically large vessel thrombus, and for which I required to put in a stent so that, and this surgery was done with some amount of heparin on board. You can see that this is still possible to do these operations. Again, this is pre and post operative. Now, this one shows that concept. I think the last video I could not show, but this is where the separation comes in. So you have the thecal elements on the top, and the McDonald was used to push the posterior wall and the tumor material away. So you create a space inside and you push the posterior wall away. And that is what is the key thing or key step in separation surgery. Now, this is the L4, and here I've done an L4 pediculectomy. Since it's a lumbar spine, we have to keep the nerve roots intact, but there's enough space to do work between the two nerve roots. This was about 180 cases of mine with 2-year follow-up or follow-up until their death. This has been published in Global Spine. It's about 2 years ago. You can read it and you get a full concept of how to do this operation and the outcomes of this particular surgical procedure. I'm happy to take any further questions if you so desire. Because this is a special situation, tubular approach to or minimal access approach, I think that if there are questions, I can definitely answer them now or even on Saturday or Sunday when we do the practical session. Thank you, guys.
Right. Thank you very much, sir. And this session is in 3 phases. So we have further discussion on during dry bone as well as in cadaveric. Thank you very much, sir. So you
Pleasure,
can
my
take
pleasure.
questions in the chat box, and so we'll conclude. So this is our last talk. Dr. Nandan, you wish to conclude?
Yes, sir. This is the last talk.
Yeah.
So, thank you, Naresh sir, for being present with us at an odd hour despite the logistical challenges. Thank you so much
No
for joining.
worries. No worries. My pleasure again.
It was a brilliant talk, sir.
Yes.
Vishal, again, I enjoyed your talk. You do daring surgery, much daring than what I ever taught you to do. You are far ahead of me now.
I
Thank
hope
you.
there's some
And
Thank
truth.
same,
Thank you.
Dheeraj as well. His scoliosis corrections I've seen are so fantastic, so
I
impressive.
Thank you.
agree with you. He is the original Indiana Jones of spine surgery in Mumbai.
Yes, true.
And we all look up to Vishal for his MIS cases. Thank you. Thank you, sir. So,
Pleasure.
so we have. I'll just mention our next SMISS event, which is going to be there, and also I will take an opportunity to inform all of you about ACSR live surgery event. It's a live surgery course. It's a 2 days event where we are planning to have 20 to 25 spine surgeries of all the spectrum from endoscopy to MIS to open to deformity to CVJ, and all the complex cervical spine cases are being planned during this 2 days event. And third day, we have planned for 2 cadaveric courses. One is CV junction and one is endoscopy spine. So we wish all of you please do register and join us for this event also. Thank you very much for joining, and we'll continue to our second phase, which is going to be there during SMISS conference. Thank you very much, sir.
Pleasure.
Okay.
Thank you.
Yeah. So, so thank you, Dheeraj. Thank you, all the faculty. It is just a curtain riser. This is just the prequel. The game is still show abhi baki hai. Hopefully, we all will come together and have a great time at Taj, and that is what we are looking forward to.
Yeah.
So, from
Yeah.
the organizer side, I really thank all the hard
Yes.
work done by Dheeraj, Nandan, and everyone. And let's come together and enjoy and have a great academic
Thank you.
feast and a good time. That's all we wish,
Yes.
and that is all we are looking forward. So,
Yes. So Thank you very much. So till now, everything what you have was I've been seeing the program, Ayush. It is looking amazing. The venue looks exceptionally good, and we are looking forward for the event. Thank you.
Okay,
Thanks,
bye
Ayush,
guys. Bye.
as well.
Bye. Good night.
Thank you.
Pleasure.
Bye.
Bye.
Thank you, sir. Bye. Good night.